Morning, everybody. Go ahead and get started this morning. Welcome. My name is Ross Milner. I'm a vascular surgeon here in Chicago. I have the pleasure of running our aortic center at the University of Chicago. Thank you very much for the opportunity to be here this morning. Dr. Golzar, who was in the back of the room someplace, thank you for the invitation to do this. What I'd like to do over the course of about the next 40 minutes, so I don't run past the allotted time, is go over the experience with the Endurant device and use this opportunity to share with you some of the clinical trial, both from the IDE study as well as from the registry that's been done, and show you where I think the clinical benefit of the device is, and then also share with you some of my cases which have been challenging anatomy that have done very well with the anatomic constraints that these patients provided, and we got what I think look like technically good results and outcomes that look good. Clearly, I'm up here and I am a consultant for Medtronic, so that is my appropriate disclosure for this. So the Endurant experience, what I'd like to share a little bit is to go through some of the access and challenging anatomies that have led to the device design and the success of the device, look at the 3-year data that's now available from the US IDE trial that was completed a couple years ago, look at the results from the ENGAGE registry, which is a worldwide registry, which I'll discuss in more detail when we get to that point, and the 2-year data that's been with sufficient number of patients to be able to make some good comments based on the data that's been accumulated. And as many of you in the audience may know, there's been a recent indication and approval for the AUI device, and show you the data that was available to allow for that and the good outcomes with that. And also, as I mentioned, I'll share with you some of my AUI experience in terms of cases that are appropriate. So as many of you in the room know and have had the opportunity to put in this device, this deals well with very challenging neck anatomies as well as very challenging iliac anatomies. The reason that that is the case are the flexible and conformable stent graft design, which allows you to deal with the indication of the 10-millimeter neck angulation that can be pretty challenging at times, and as well the low-profile nature of the device and the hydrophilic coating with the sheath allows us to traverse some pretty challenging iliac anatomy. And I'm sure a number of you in the room who have had an opportunity to implant this device have cases where you struggled a little bit to determine whether or not you thought the iliac access was adequate, and have been pleasantly surprised at how well the device dealt with some very challenging iliac anatomy. The proximal deployment is well designed. It's very accurate. It allows you to correct for parallax and really be precise with when you're trying to deal with challenging necks and with complex sort of paravisceral anatomy. The graft material is a polyester graft material, as you're aware of, and there's active suprarenal fixation, which I think is valuable in terms of migration prevention, which will also play out when you look at the IDE data. So where is this device designed to treat, and what type of patients can we treat? So the graft sizes range in the main body from 23 to 36 millimeters, and the iliac rims range from 10 to 28 millimeters. The vessel that can be treated based on those diameters for the infrarenal aorta for the neck ranges from 19 to 32 millimeters in diameter, which will allow for that 36 device. And the iliac dimensions are 8 to 25 millimeters, which again, that 28 millimeter device can treat the 25 millimeter anatomy. The profile is relatively small for this size device, 18 French or 20 French for the main body device, with the 28 millimeter device being able to be placed through an 18 French delivery system, and the limbs through a 14 or 16 French delivery system, depending on the size that you need. And again, the way the device is designed and the delivery system is, it really will track through some pretty challenging anatomies. One of the really nice aspects of this is the proximal deployment. As I mentioned before, it's very precise. You can correct for your parallax. The slow, deliberate, and accurate proximal deployment is relatively easily accomplished with the device design with the pinwheel, and you're able to bring it around, and very controlled release of the suprarenal fixation, which again, I think those are, when I think of sort of my EVAR challenges, and actually later today I am giving a talk on managing complications of EVAR, and one of my main points, if you don't want to stay for my talk this afternoon, is the way to manage complications is your preoperative planning. And when you plan for these cases appropriately, you can eliminate a lot of the complications that occur. And one of the benefits with this is you plan appropriately, you can get the device in appropriately, and it does what you want it to do, and it's accurate in terms of the way it handles the neck. So what clinical trial data is there that's available? for all the patients that have been treated. Excuse me. So there's over 1,800 patients that have been treated. There's the AUI, which has 44 patients, has 1-year data. There's an EU trial that was led by one of my good friends, Hans Verhagen, who had 80 patients. There's an IDE bifurcated arm, which has 150 patients over a 3-year time. And then Engage, which has a huge number of patients, but data, as I mentioned, up to 2 years for 500 patients. And enrollment's been completed for Engage in the US as well as Endurant in France. So what does the US IDE trial look like? So this trial was 150 patients. It was performed in a prospective, multi-center, non-randomized fashion, 26 U.S. sites. And one of the things that's relatively impressive to me with this trial is if you look, it was accomplished basically over a 13-month period of time, which is pretty amazing for any clinical trial. That's a fair number of patients enrolled in a short period of time. And I think from my perspective, what that highlights to me is the investigator's confidence in this device. And you're looking at essentially over 10 patients per month with a relatively small number of sites, and it's pretty good. The primary safety endpoint was any 30-day major adverse events. The primary effectiveness endpoint was successful aneurysm treatment at 12 months, and follow-up is done in the standard fashion with 30 days, 6 months, 1 year, and an annual follow-up through 5 years. The anatomic requirements as part of the IDE trial were at least 10 millimeters of infrarenal neck. There was less than 60 degrees of infrarenal angulation, and with the way the suprarenal stents are designed, there had to be less than 45 degrees of suprarenal angulation. And one of the unique things with this trial is a lot of other trials didn't have an appropriate sort of comparison cohort, but this was compared to the Talent trial, and you could get a sense of really comparing device to device and outcomes based on that. The demographics are pretty typical for what we see for a standard bifurcated device, which I'd like you to remember this slide because you'll see a completely different demographic based on the AUI device, and I think many of you would understand why, and we'll talk about that more when we get to that point. The mean age was 73 years, predominantly men, 91% men, and approximately 9% women treated in this trial. When you look at the baseline, excuse me, the baseline aneurysm characteristics, the neck diameter, the mean was 23.5 with a range from 17 to 31. This is core lab measurements. This is not site measurements. So after the patients have been enrolled, it will go to a core lab to confirm, and these are the core lab measurements. The mean neck length was 31 millimeters. The diameter of the aneurysm was 56 millimeters with an infrarenal neck angle of approximately 35 degrees. The iliac fixation on both sides was about 14 millimeters in terms of the diameter of the iliac vessel that was treated. How did the procedures look? Overall, very good. The duration was 101 minutes for the procedure, which I think is a pretty good time to put a device in. The majority of patients were treated with general anesthesia. Obviously, this is going to be a very investigator-specific preference in terms of how they like to do it, and also an institution preference. Some people prefer to do it under local or regional anesthesia, and others general. I think this is not really a marker of anything other than sort of treating physician preference. Blood loss was low, 185 cc's, hours in the ICU, 6 hours, and hospital stay in days, 2. And I think when you'll see, I'll show you the Engage data. The one caveat with the Engage length of stay is in different countries around the world, the requirements are different in terms of the hospital stays and reimbursement, and it's not always a perfect marker of actually patient outcome because some places the requirement is you have to be in the hospital for a couple days to be reimbursed appropriately. The successful deployment was outstanding, so 149 out of 150. The one case that could not get accomplished was a scenario where the main body device was able to be placed. There was tremendous difficulty cannulating the contralateral limb, and the decision was made to convert that patient to an aorta or uni-iliac device with a fem-fem. So it's considered a technical failure because it wasn't placement of a bifurcated device, but the patient actually had an appropriate result and has done well. But it's brings that number down to the number that you see because it wasn't the successful placement of a bifurcated device. So how do the 3-year results look in terms of the data that's available for these patients? Well, they're outstanding. The type 1 endoleak has been very low. When you see at 3 years, there's a 0.9%. There is one patient who did develop a type 1 endoleak, and although the post-implant rupture at 3 years says 0, this patient decided not to have this type 1 endoleak treated, and once again reinforces for all of us a natural history of an untreated type 1 endoleak and went on to expand and rupture. It's not listed under the 3-year data because he actually ruptured after that time point. point. And when the data set is updated for the 4-year data, there will be a post-implant rupture in there for this patient who decided not to be treated. Migration has been outstanding, and there's been no need to convert to any open repair for any failures of implants. How about SAC changes? That's what we all care about. How are we doing in terms of looking at how do these patients do afterwards? There is a very small number that do have an increase. It's more than 5 millimeters at the 3-year time point. It's less than 5%, but the overwhelming majority have a stable or shrinking sac. And when you look at that, 95% have a sac diameter that's decreased or stable at 3 years, which is really outstanding. And I think as you look at it over time, one of the nice things is there's a conversion even from the patients that are stable in the first year or two to more of them starting to shrink to year 2 and year 3. So I think it shows once again the aneurysm sac behavior. You have it appropriately excluded, it'll start to shrink, and that's what we want to see, and that's what's going on with this patient subset. So at 3 years, and as I said, there is one patient will have aneurysm-related mortality at the 4-year data point, but at 3 years, there's 100% freedom from any aneurysm-related mortality, and that is from a good number of patients that have been evaluated. When you look at the necessity for secondary procedures, which is something we're all concerned about with endovascular therapy, and one of the concerns, obviously, that gets raised in the literature frequently in a lot of these discussions is, sure, you can change the immediate perioperative morbidity and mortality, and we do a better job with endovascular repair compared to open repair, but one of the Achilles heel of this technology is that multiple interventions need to be performed down the road. And as you can see here, for at least from this trial, it's been a small number of cases. These are the actual interventions that were done for the type of problem over the time frame. So during year 1, there was a couple type 1 endo leaks that needed to be treated. There were some limb occlusions and then also some limb stenoses. That limb occlusion problem went away for patients in 2 and 3 years of follow-up, and more what you were seeing is type 2 endo leak issues and the necessity to treat, my guess is, expanding sacs in the setting of a type 2 endo leak, which again, I think there's some controversy with that in terms of how people manage type 2 endo leaks, and it's not really the point of this discussion, but interventions were done for those. So in summary, when you look at the IDE study, the stent graft delivers sustained clinical performance when you look at the key endpoints at 3 years, and the outcomes from this are robust and really confirm the durability of the stent graft in what can be challenging anatomy and scenarios where it's done very well. So I think for a lot of people in the audience, one of the criticisms of IDE type studies is that these are, quote unquote, the cherry-picked patients, right? These are the people who have the best anatomy, who we know have sort of appropriate survival and are going to do well in terms of they wouldn't be clinical trial candidates and wouldn't be accepted in a clinical trial unless they were the best patients. So I think one of the really great things about what's been done with studying this device is fine, the IDE data looks phenomenal, and I think we're all pretty comfortable when you look at that. That's something we would want for a patient we're taking care of, or for a family member for that matter. But what happens in the real world? And I think that's where Engage is really unique, because this gives us a much better sense of real-world data. For those of you sitting in the audience who say, well, fine, I'm not doing clinical trials, but I'd like to fix aneurysms, and I want my patients taken care of appropriately. What do my patients look like? And I think this gives us a better sense of what that looks like. So what is Engage, for those of you who aren't familiar with it? It's the Endurance Stent Graft Natural Selection Global Post-Market Registry. It is truly amazing in terms of the number of patients that have been included in it and the way it's been done in terms of the monitoring. So it's over 1,200 patients that have been consecutively enrolled at centers that were considered relatively high volume, which is over 20 aneurysm repairs per year. And it's non-randomized data, and it's 80-plus high-volume centers worldwide. The first patient was treated in March of 2009. Again, similar endpoints that you're looking for with the IDE trial. Primary safety endpoint is 12-month treatment success, and then follow-up was done at 30 days, 1 year, and annually through 5 years. So it's a large registry. It's data monitored, which makes it different from the typical registry because it's not just sites putting in data, it's actually data monitored, and there is an independent CEC to adjudicate any events that occur. So it's not a typical registry from that standpoint, but it still has some of the characteristics of a registry in that it doesn't have the limitations of an IDE study in terms of the anatomic limitations. This is what it looks like from the worldwide portion of this. You can see the different parts of the world that participated and the patients enrolled from all over the world, which I think, again, is a good sample of a diversity of patients that can be treated. And as I mentioned several times already, this is the largest contemporary EVAR registry currently, and really provides us some interesting data. So why? Prospectively collect real-life data, as I said, real-world patients, real-world practice, and create a database that be pooled and compared with other available stent graft data. And for those of you in the room who had the opportunity to go to Charing Cross earlier this year in London, I was fortunate to be able to moderate a session talking about ENGAGE. And one of the things that's really clear to me is the four investigators and really prominent guys who spoke. I just got to sit there and make sure they did the right things, really showed the value of this, because they've all looked at different aspects of success or challenges with EVAR and been able to study it in a way that we haven't been able to do very well before. And one was looking at gender differences, one is looking at neck differences, and with this number of patients, you're able to really ask a question and answer it. And it's a valuable research tool in addition to being able to understand what goes on in a real-world practice. So at 1 year, there was 1,263 patients enrolled. There's data available at the 2-year time point for 500 patients. Similar baseline demographics to what you saw with the IDE trial, and again, remember this slide because it's completely different than the AUI. Mean age was almost identical, 73 years, almost 90% men, a little over 10% women. Here's the baseline risk factors that were accumulated for the patients that were enrolled in the ENGAGE registry. About half were smokers, 3/4 had hypertension, high percentage had hyperlipidemia. You can see the other risk factors, including approximately half had cardiac disease. So I think represents well the patients we take care of. When you look at the ASA risk stratification, the majority of these patients were class 2, 3, and 4, and in fact, most of them were class 3 and 4, so high-risk patients, as we would expect from aneurysm disease patients. And again, same type of thing when you look at the SVS, ICVS risk scores. These are high-risk patients, and we know that. Any of our aneurysm patients are high-risk patients. What are the baseline aneurysm characteristics? The neck diameter was pretty similar to the IDE trial. The proximal neck length in 12% of these patients was less than 15 millimeters, and there's actually been a lot of work done looking at this percentage, this group of patients and looking at these short neck anatomies that were treated and the outcomes, and it's actually been very favorable. The mean AAA diameter was 6 centimeters. The infrarenal neck angle was approximately 30 degrees for a mean, but just slightly over 10% had greater than 60 degrees of angulation. So again, these compromised, challenging necks, and that's really been looked at, and these have done well. The iliac fixation was almost identical to what you saw in the IDE with approximately 14 millimeters in diameter. What's interesting, and I'm not going to go through every one of these listed here, but what we would truly consider IFU, almost 20% of the patients included in the registry thus far have been what would be called beyond IFU for different reasons, either angulation, shorter necks, challenging iliac anatomy, for the reasons that you would think of, but approximately 20% are outside of the bounds of what is typical IFU. So it really gives us a chance to investigate how we do in those circumstances. And I think we all get concerned when we push the envelope, we're not getting the long-term results we want or potentially may see. And so this is going to be an important subset to look at further. 16% of these patients were symptomatic aneurysms, 11% were class 4. As I mentioned, 10% were female, and again, it's going to be much higher in the AOI group, and 12% had a proximal neck length of less than 15 millimeters, and I think these points are important to recognize. The characteristics are pretty similar to what we saw with the IDE study, slightly shorter procedure time, 99 minutes. The anesthesia, again, this is a very investigator-specific sort of decision-making, but still predominantly general anesthesia, but there was much more of a mix in the registry. Blood loss was a little over 200 cc's. Hours in the ICU were a little bit longer, and again, I think you have to be careful when you look at the hospital stay. It doesn't necessarily reflect that the patients were sicker, it didn't do as well. This is a very country and region-specific decision-making, and sometimes it has nothing to do with actual patient care, but reimbursement issues, so you have to be careful with that. Deployment was very high. In the ones that didn't deploy well, there were some issues with iliac access in a couple of them where there was a decision made not to proceed. There was a tip capture issue with one of the patients that made successful deployment challenging. But overall, when you look at over 1,200 patients, to only have 7 where there was issues with deployment and challenging anatomy, I think is very favorable. How about the outcomes? The technical success was excellent, 99%. Intraoperative clinical success also excellent. And then the freedom from intraoperative death was very high, 100%, can't be better than that. And freedom from type 1 or type 3 endo leaks uncorrected is very high as well. When you look at the major adverse events, there is other mortality, and we know this happens from these patients being sick at baseline. Bowel ischemia can occur. There's patients that have cardiac events afterwards. Thankfully, paraplegia was 0 with this. And procedural blood loss greater than 1 liter was a very small number, and also a very small number of renal failure and other problems that can occur. So overall, a very low number of major adverse events, and this is taken from a big cohort at 1 year and obviously approximately the 500 at 2 years. Mortality is low. There is some aneurysm-related mortality. Part of the reason this number is the way it is, 16 of those 19 occurred within the first 30 days after surgery and weren't necessarily related to a problem with the aneurysm itself, but were a perioperative mortality. So whenever it happens, by definition, within 30 days of the operation, it's considered aneurysm-related mortality. And that's true for any intervention. So if someone comes back for a secondary intervention, and if for some reason has a complication within 30 days of their secondary intervention, that would be considered aneurysm-related mortality as well. So you have to be a little careful when we look at that number. So the overwhelming majority of these, the mortality rate was secondary to problems that occurred in the perioperative period, not related specifically to the aneurysm itself, but can clearly be related back to the procedure in some way. So that's why this gets classified the way it does. So freedom from all-cause mortality is 86% at 2 years, and I think, again, is a reflection that these patients are sick patients. And I think when you look at the 5-year data, you know, we've seen this with other trials. I mean, all-cause mortality is somewhere around, you know, 50 or 60%. This is a sick group of people we take care of. Freedom from AAA-related mortality is very high, 98% at 2 years. And freedom from reintervention is very impressive as well, 93% at 2 years, so a low need for secondary interventions to be performed. Endo leaks have been low. And when you look, again, this is the 1 year and then the 2 year numbers, and this is where data has been available for these folks. So although there is data on 500 of them, the endoleak data is available on this number and is still being accumulated. The majority of the endoleaks are type 2 endoleaks, and at this point I can't give you an idea of what the SAC behavior has been with those folks, but about 7% of type 2 endoleaks. But when you look at this, the diameter changes overall are very good. There's a very low number that have an increase. The overwhelming majority, 90+%, obviously have stable or shrinking sacs. Stent graft migration has been low, including when you look at proximal, there has been some limb separation that required other interventions. There was a small number of stent graft occlusions, and I think we've learned to be careful with, there's a balance between the ability to get this device in, which is really good, but the care that we need to take to deal with really challenging iliac anatomy and make sure we've treated the limbs appropriately, and I think we've learned that. So we're careful with this risk of stent graft occlusion, and there's been no bare stent fractures for the suprarenal fixation. The conversion to open surgery has been very low. The aneurysm rupture rate, again, has been very low, and the need for secondary endovascular procedures, as you can see, is about 6%. And it's been even lower when you look at the necessity to treat either a type 1 or type 3 leak. Most of the secondary interventions have been done for other reasons. And when you compare this to some of the other work that's been done looking at secondary interventions, for the DREAM trial and for OVER, there was a 12% and a 14% essentially secondary intervention rate. With the Endurant IDE, the freedom from reinterventions was almost 94%, and engaged so far, it's 6%. So obviously, ideally, we'd all love this number to be 0. I think when you're talking about devices and challenging anatomy, there's no way to technically be able to do that. And again, I'm giving away another one of my talks this afternoon, and one of the other talks I'm giving is on surveillance. And the main point from that, if you want to miss that talk as well, is I think surveillance is crucial. There's a lot of literature coming out saying you can skimp a little bit. I think skimping leads to problems, and we know that. And I think you know that overall the devices that we're able to place now significantly improved over 10 years ago, but we still need to follow patients, and there is no such thing as a 0 reintervention rate right now. Hopefully one day there will be, but we don't have that right now. So in summary, from what we see from ENGAGE, the Endurant stent graft continues to demonstrate safety, durability, and efficacy for the treatment of AAAs across a broad range of patient populations and anatomy, which I think this is really one of the most amazing parts of this. And the need for reintervention through 2 years is very favorable when you compare it to the earlier endograft devices, which is what DREAM and OVER represent. So longer-term data is clearly needed, but the early markers of EVAR success are demonstrated by Endurant. There's no migration, there's low rates of sac enlargement and needs for reintervention, and there is a significant amount of staxability and even more of sac shrinkage. So there's going to be more data that will come from this. There'll be follow-up at 3 years now, and for those of you who will attend, this is your little preview for VEITH. there'll be an update, and you'll get more data. So what does the IDE trial look like in terms of the AUI? So as many of you in the audience know, I think the limitations that we have for bifurcated devices and success with EVAR can really be put in two main sort of buckets: challenging neck anatomy, challenging iliac anatomy. That's where we really, as treating physicians, struggle. So how can we do better with some of the real challenging aortic bifurcations or iliac anatomy? And this is what the AUI allows us to do. So this was a 44-patient trial. Again, prospective, multi-center, non-randomized data, 15 sites over a little over a 2-year period of time, which again, I think versus what I told you with how the Endurant IDE trial ran and how quickly that enrolled, you can see this is a smaller number of patients, but there is a need out there to do this. Primary safety endpoints are similar from what you saw before, any 30-day major adverse event. Effectiveness is composite technical and clinical success at 12 months. Follow-up, the standard protocol, 30 days, 6 months, 1 year, and annually through 5 years. Again, 100% data management review, core lab, and this just received approval in April of this year. So adverse iliac anatomy, calcified or stenotic aortic bifurcation. We all have sort of different definitions in our mind of what we consider a really narrow bifurcation. But for me, as I look, I make a distinction based on diameter in conjunction with the extent of calcification, and it really helps you decide when you think it's too narrow to be able to have a standard bifurcated device in there. The other anatomic requirements were similar to what you saw before. Neck length of about at least 10 millimeters, angulation of 60, diameters of 19 to 32, with the distal fixation length of approximately 15 millimeters. Similar iliac diameters that you saw before, and appropriate morphology for aneurysm repair. This is, to me, one of the most important points of this. I think as we take care of more older, sicker patients, and what you see is more women having challenging access than men. And that's where this device may really play a role. As you can see here, it's 32% compared to the other two I showed you, which were 10% or so. So a large percentage of the patients treated in this AUI trial were women. Neck diameter, similar to what you saw before. Neck length, similar to what you saw before. Angulation, all this is relatively similar. The AAA diameter maximum is a little bit less, but I think part of the reason you see that is when you make a comparison of the AAA diameter to the other vessels and you have that sort of 2 times the standard size of the other vessels, that's where some of these decisions are made. So some of these aneurysms are a little bit smaller based on the other arteries being much smaller. The iliac fixation was similar. I've highlighted here a couple points which I think are important. I've already mentioned, but when you compare it to the bifurcated trial directly, almost 4 times higher number of women in terms of the percentage, a sicker subset of patients overall, and I think we all get that as we see more occlusive disease associated with aneurysmal disease. These are a sicker subset of patients. So a higher percentage with COPD, a higher percentage of smokers, a higher percentage of carotid disease, higher PVD, and a much higher ASA classification of 3 or 4. So a sicker group of patients, more women with challenging access. Duration was good in terms of the time the procedure took. Again, approximately 80% general anesthesia. Blood loss was a little bit higher. From my experience, this usually is from calcified femoral vessels that are associated with this complex iliac anatomy as well. Hours in the ICU were a little bit longer and a little bit longer length of stay in the hospital. Successful deployment was outstanding. Again, one case where it couldn't be deployed. The successful treatment has been great. Aneurysm rupture, and the data obviously through 1 year looks very good, which led to the approval of the device. And again, diameter changes has been very good, and this is at 1 year time frame with a very low endoleak rate, and the endoleaks have all been type 2 endoleaks right now. So as I mentioned, no type 1 or type 3. So far, no migration at 1 year. Hopefully that will stay that way. No post-implant ruptures or other reasons that anything other than successful repair has been reported. So clearly, several anatomic situations can lend themselves appropriately to an AUI device. Then in that scenario, it will do better than a bifurcated device would. The results at 1 year are outstanding and obviously allowed for approval. And overall, this patient population that requires an AUI is a sicker patient population and tends to be more women. So I'm going to show you a few cases and then leave some time at the end for some questions if people have them. And I'm going to show you a couple cases with challenging anatomy for bifurcated devices. I'm going to show you one aortoiliac that I already treated and one that's coming up actually on Monday. So I'm going to give you a sneak peek, and then through the grapevine, the people that live in Chicago will probably end up hearing how it goes anyway. All right, so here's a very difficult case. This is a fragile woman, single kidney, pretty challenging neck anatomy. The aortic bifurcation is a little small, but thankfully not too calcified. And when I initially looked at this film, I was very concerned about limb cannulation because of the angulation in the neck. And as well, you can see there's sort of almost like a dumbbell in there, and that there's two stenotic areas within the aneurysm neck. And I was really concerned about being able to open a contralateral limb in this case. This gives you an idea of what that looks like. So here's neck diameters. The neck length was reasonable, even though it was pretty angulated. But 10 millimeters down, there was significant disparity between what you look like at the proximal neck, and then it dilated up again. So that stenotic area, although I think it's good in terms of getting you a seal, also could potentially make getting the contralateral limb open appropriately a challenge. Again, here's what it looks like in terms of that neck and length from the left renal to where that bend in the aorta is, which was just over 3 centimeters. Here's the iliac on the right side. Not bad in terms of diameters. The axis was a little bit small, but not calcified. And then on the left side. Here's what this looks like. And again, one of the things that I really feel that we can do to prevent complications is to prepare appropriately. So given the fact that this woman only has one functioning kidney, I wanted to really preserve and make sure that I wouldn't have an issue with that kidney. I ended up putting a wire in there and having a sheath ready to go. If for some reason with the challenging neck anatomy I had compromised that left renal wall, I was prepared to treat it, but I knew I would be much better off having that ahead of time and being prepared for it. And as I'll talk about later, I think the way you manage these complications is to try to prevent them from happening, and I didn't want renal coverage, especially with someone with a solitary functioning kidney. Here's the main body device in place. And then this shows you I specifically tried to stay a little bit down so I didn't land in that very narrow area, but I also didn't want, in trying to do that, to have the device potentially come up and cover that renal. And as I said, that's why I had that wire there. But here I'm completely protected. You can see how nicely it dealt with that angulation in the neck, and I did not have any problems with the cannulation, and actually tried to put the device so the contralateral limb was slightly anterior, and that worked very well. And then I showed you another angiogram here a little bit further in this run to show you how nicely the device did through that aortic bifurcation with a cross-limb approach here, and really nice result into those iliacs. So a technically good result. No endo leak, and this patient has done very well. And I think from my perspective, when I'm dealing with a solitary kidney like this, I need to be mentally prepared with challenging anatomy to be able to deal with the left renal if necessary, and that's what I did. This is a patient that got presented with a symptomatic aneurysm. You can see this very challenging neck anatomy off this coronal section from a CT scan. And in addition, what you don't recognize on this image, but you'll be able to see better on this image, there was a dissection within the aorta as well. So although this was aneurysmal, there was also an area of dissection, and there was not a great neck here. Again, a lot of times when I have these scenarios, I like to prepare from above, which I did here, and I had a sheath in place, but I was hoping to try to just get this device in. This is an 88-year-old woman who is relatively fragile. I was trying not to be too excessive with what I did. And here, although when I finished this case, I thought I had covered more than I would hope to, but was really sort of right at the renal, she actually did very well, maintained her renal function, and has had a good result, which, you know, when I went into this case, I was just assuming I was going to cover renals and just be done with it and be able to save her, but not be in a circumstance where I was going to preserve renal function, and explained that pretty well to the family. And I was really pleasantly surprised I was able to deal with this in a technical fashion that worked well, and she was able to maintain her renal function. So a really, from my perspective, a really outstanding result. So here's an idea of where the AUI would work. I actually did this case before the AUI indication was available. This story is actually really interesting. This is a woman who has a renal cell carcinoma who had a big mass on CT scan or aortic bifurcation that they thought was tumor because they had an unenhanced CT scan, and had her set up to have this thing biopsied. And they got an enhanced CT scan the day they were going to biopsy it, and found this huge saccular aneurysm at the aortic bifurcation rather than a big tumor, which they thought it was. I'm sure the phone call I would have gotten if they biopsied the saccular aneurysm would have been interesting as well, although it was still pretty interesting as is, but the needle in the aneurysm would have been, I'm sure, relatively exciting. But as you see here, and it just gives you a quick look, but this is a relatively calcified bifurcation, not horrible. One of the things I didn't appreciate on the CT scan until intraoperatively I did the angiogram, this aneurysm was compressing the left common iliac artery in a really significant way, and more so than I appreciated from the CT scan. You can see this here Here's from an intraoperative angiogram. I was a little concerned the bifurcation was a little bit narrow. Went into thinking I may need to put a uniiliac device in. And when I shot my initial angiogram and saw what that left common iliac looked like, I really thought that I needed to at that point. And you can see how narrow that is just around the pigtail catheter. I actually tried to dilate that up a little bit, and I could not get that thing to open up at all, and it was really, really compressed by this aneurysm. Here's what that looks like after a little bit of dilation. And I still could not get a significant enough lumen in that common iliac on the left side to be able to comfortably put a bifurcated device in. Here's what that aneurysm looks like, pretty impressive. And as I said, I'm sure it would have been even more impressive with a biopsy needle in it. And here's what an end result looked like with completion angiographic images, and then put in amplats on that left side to occlude it. And this is what it looks like on follow-up CT scan. She's actually done very well from this on sequential imaging, this aneurysm shrinking down, and she has actually had a nice oncologic result as well. And you can see a nice result with the AUI and then the fem-fem bypass. This is the one I have coming up. This actually, by someone who's very skilled in the local community, tried to treat, could not get sheaths up appropriately because of the calcification in the arteries, and I'll show you that, and was sent over to try to see if there is a way to handle this from a conduit approach, which I think there may be. So you can see challenging neck anatomy here, and you can see the diameters, but a doable neck in terms of the diameter and in terms of the length. And then really calcified, really tortuous iliacs that I'm hopefully going to be able to get a conduit on and be able to get the device that way. But this should be an interesting case. So overall, in summary, I think the Endurant devices, both the bifurcated and AUI device, can treat very challenging anatomies. Both the clinical trial and the registry results are very impressive for aneurysm treatment and the success that we can look for with our patients. And I think these handful of cases that I show you really demonstrate the success of the device in really challenging anatomy and dealing with both anatomy that's difficult with the neck as well as challenging iliac anatomy. So again, thank you very much for the invitation this morning, and thanks everybody for your attention, and I'm happy to answer any questions. I heard it was a late night last night. I guess everybody's still recuperating. Well, if not, thank you very much. Grab some coffee, and then I think we start again at 9. I don't know what time it is. So 5 minutes. Thank you.
Forgive me if I act a little strange, for I know not what I do. Feels like lightning running through my veins every time I look at you. Every time I look at you. Help me out here, all my words are falling short, and there's so much I want to say. Want to tell you just how good it feels when you look at me that way. When you look at me that way. Throw a stone and watch the ripples flow, moving out across the bay. Like a stone I fall into your eyes, deep into that mystery.
This is corner and everything.
Won't ever have to say goodbye.
Right here. I'll take it.
Whoa, whoa, whoa,
To make any sense.
whoa, whoa, whoa.
Good morning, everyone. Good morning, good morning, good morning. It's almost time to get our program started here, so if we can kind of get everyone seated so that we can kind of get this particular symposium going. We have some very, very distinguished faculty guests here that we're certainly honored to have, and we want to get everyone's undivided attention. So if we can get everyone in the room and kind of situated. So Jaffa, if you can clean the corridors out there and bring everyone in. Thanks.
I know not what I do. Feels like lightning running through my veins. Every time I look at you, every time I look at you, every time I look at you, every time I look at you.
All right, we're right at 9 o'clock here, and again, I just want to get this portion of the symposium going here. And I am extremely honored, as well as Dr. Gozar and other members of the planning committee and the board, to really partner with ISIS this year on this particular portion of the meeting, the Aortic Summit. And I am humbled and honored to be amongst such distinguished international faculty members and meetings and mentors as Dr. Dietrich and Dr. Krazier, as well as some of the other local talent guys that are nationally renowned as well in this audience. I think it's really a treat. So without any further ado, I'm going to introduce Dr. Dietrich to talk about ISIS, and I don't think anyone needs any introduction about Dr. Dietrich, who is internationally renowned and, gosh, is a mentor to folks all over the country, and not to mention on the international circuit as well. And he's a true icon, and we are truly honored to have him here today. Dr. Dietrich?
Well, thank you very much, Paul. It's great to be with you, and we really appreciate this invitation to have ISIS join in preparation for this aortic session. Most of you probably don't know what ISIS is, and so I'm going to spend just a few minutes discussing this. And I asked the question, why do we need a vascular specialist, the Society for Vascular Specialists? And I think it's going to be pretty clear in a couple of minutes why we are on a mission. The technology basis for our future endovascular evolution is actually under siege. You may not appreciate that, but it is true. Individual freedom is being restricted more than ever before, and that's going to increase dramatically. Technology development is under greater scrutiny than it ever has been by both the corporate and the government levels. I don't think we saw this issue of endovascular today recently, but they hit the nail right on the head when they're talking about the problem with innovation in the future. Regulation, reimbursement, new legislation will affect vascular care and technology. And then very importantly, it's going to be barriers to our our ability to innovate in the future. We don't know what the final result of Obamacare is going to be, but we do know already that the companies are facing a 3% tax on every device that they sell. Now, what does that mean? That means to us, as investigators and research people, it means that they're going to have to cut back on industry support. We've already seen that. I'm sure the organizers of CV cardiovascular here have also seen this, and it has a dramatic impact on how we're going in the future. The regulatory climate is under severe change. This is a slide I had made up called the 7-year gap. This may be alarming to some of you, but it's 7 years faster outside the United States to get approval for a device than it is in the United States. Now, what does that mean to us? It means we're not going to have a lot of the latest technologies for us to use in our own patients. It is indeed a fact that many OUS countries have devices, technology, study results, training programs years before we do in the United States. And that's why so many people these days are going to other countries for their training. Major training efforts and premier opportunities are no longer in the United States. If you want to have the most advanced technology, OUS prevails. In fact, I hate to show this slide, but the U.S. has surrendered its position as the global leader in interventional therapeutics. And this is pretty sad, I think, for all of us who've worked so long in this area. Our present environment has changed dramatically, and this is going to continue. So the question is, how do we face this? How do we restructure to face the obstacles looming in the future? And that's why I bring up the International Society of Endovascular Specialists, because I think this is an opportunity. This society is unique in the world. We started in 1993. It's the only international society that is a 501c3. And that also is very important as we move forward, because if you're a charitable organization, a 501c3, it may give you some advantage. It is the only society in the world that's made up 50% board members from industry and 50% of physicians. This is extremely important because it gives us as physicians an opportunity to have dialogue with the manufacturers, the corporate people that are working on the devices that we're working on. We have really, from the beginning, we have dedicated this as a multi-specialty organization. We're interested in cardiology, cardiac surgery, vascular surgery, interventional radiology, and as we move on, other areas of specialty also. The focus is entirely on endovascular treatment, training. We have done some research projects with ISIS, but mainly we're looking at training. And we really have a global vision with this. We have the Journal of Endovascular Therapy is controlled by the society. Most of you, I'm sure, have seen this. It's an excellent peer-reviewed journal. It has interdisciplinary editorial board. The very best people in the world are on this board. It's probably the most exclusively read journal on just endovascular techniques. It has a high impact factor, which makes it very appropriate for all of our readers. And it has now, we have an online version as well. The annual meeting this year, it's our 28th meeting, we call it not ICON, we used to be called the International Congress. It's ICON, and it's going to be held in mid-February, and we certainly hope that many of you can be there, and we expect we're going to be having a lot of the faculty that are here for this very important meeting join us. This is a global adventure for us. We are international, and we want to take advantage of all the people that are coming here and the people you're going to be getting year to year. So we hope we can form a partnership with you. With that, I thank you very much, Paul, for allowing us to have this introduction.
Thank you, Dr. Dietrich. Again, we're truly honored about the partnership and the possibilities ahead as well. So once again, we really thank you for coming and partnering with us. The next speaker that I would like to call to the podium is, again, a longtime friend and mentor who actually got me involved in endovascular repair of abdominal aortic aneurysms over 10 years ago. So he's been a true mentor for me over the years. This is Dr. Krazier from the Texas Heart, again, internationally renowned, one of the true icons in endovascular education in the U.S. as well as abroad. And without any further ado, I would like to ask Dr. Krazier to come to the podium to talk about the PVAR trial, which is an area that he was the true pioneer in when it comes to the percutaneous management of abdominal aortic aneurysm disease. Dr. Krazier?
Thank you, Paul. I'm flattered with your introduction. He's a good friend of mine. We work together on many different projects, and I hope we'll continue to work on many different projects. I would like to thank you for inviting me to this great meeting, and Jaffer and all the other program directors. It's a pleasure to be here. I feel at home in Chicago. That's where I had my training. So talking about PVAR, several of you were participants in the trial. Mark Eskandari and Paul Jones were in the trial, as well as 20 other participating institutions. We believe we're the first ones to propose PVAR in 1999, and you can see Dr. Dietrich was my mentor at that time, a true believer in it, and for a cardiovascular surgeon to embrace percutaneous approach, it was revolutionary at that time. So I have to congratulate you to showing fortitude and guts to join a cardiologist in this endeavor. And it became a reality recently. When we look at the literature, and particularly as far as here shown PVAR single center results using ProStar, we can see that the results were not very encouraging as far as technical success is concerned from early publications, but then later the reports showed excellent results. Of course, that was related to experience and patient selection. And if we look at the literature with ProStar over the last 3 years, the technical success has been reported to be in the range of 98% from single-center trials. ProGlide is another device, and Mark will talk about techniques and how to do it. Again, the results maybe were not as good at the beginning, but then more recently, it were better by experienced operators. And when we look at the literature over the last 3 years, the success rate is somewhere around 96%, or pretty close or equal to ProStar XL. From all those reports from single-center trials, we can see that most of the operators reported shorter procedure time with the PVAR approach, lower in-room anesthesia time when a general anesthesia was used, less blood loss, fewer growing complications, and shorter length of stay. Nevertheless, the question remained until recently regarding the broader applicability of this approach due to lack of a randomized multi-center trial. So the PVAR trial was FDA-approved trial designed to compare safety and effectiveness of a pre-close technique for percutaneous femoral artery access and closure, so-called PVAR, to surgical cut-down, so-called CVAR, using endologic IntuiTrack device, which is not the latest. The latest is AFX, which is a lower profile, and Abbott vascular closure devices, which is ProStar XL or ProGlide. Study design, again, as I mentioned, was a multi-center randomized prospective. 192 patients were enrolled. There was a roll-in phase to show our proficiency in being able to do the percutaneous access and repair with the closure devices. 41 patients were in this roll-in phase, and 151 patients were in randomized phase, randomized equally to ProGlide, ProStar, and surgical access and repair. As I mentioned, in 20 centers, Northwestern and Paul Jones at Mercy were part of the trial list. Methodology, there was an independent CT review center to look at the access site anatomical suitability for PVAR as well as for the use of Intuitrac device for abdominal aortic aneurysm repair with this device. One of the most important factors was absence of anterior wall or circumferential calcification at the access site. The primary endpoint was access site closure success without any major vascular complications at 30 days, not at the time when the procedure was completed. And so the comparison was between ProGlide, ProStar, and CVAR. Now, ProStar results were reported already at one of the presentations. They were somewhat lower than with ProGlide, and this is still being adjudicated and evaluated to find the answers and to report this to the FDA. So we have ProGlide data available, and you will see the details. The ipsilateral device closure success with ProGlide was 96%. The contralateral, which is 9 French sheath, was 100%. There was no procedural or 30-day mortality. And additional analysis showed that the procedure time was significantly shorter with PVAR than with CVAR, and time to hemostasis on the ipsilateral side was also significantly shorter for PVAR. There were some few trends such as less blood loss with PVAR and lower need for blood transfusion with PVAR. However, since the numbers were relatively small in each group, this did not become statistically significant. What was statistically significant at 30 days, looking at major access site vascular complications, the PVAR fared better than CVAR, with 6% complications with PVAR and 10% vascular complications for CVAR. So the primary endpoint was achieved for this trial. As far as the minor vascular complications, even though they were lower in PVAR, this did not reach the statistical significance, but there is definitely a considerable trend, as you see, in favor to PVAR. And at 6 months, because FDA obligated the trialists to follow patients for 6 months, the majority of events, if they occurred within the first 30 days. And PVAR showed non-inferiority to CVAR, which was sustained at 6-month follow-up, as you can see here. There were secondary analysis that showed that CVAR patients required 8 times more secondary iliac and femoral artery-related procedures. And there were also other favorable trends, as I mentioned, less blood loss and transfusion, 3.5 times less need for blood transfusion for PVAR than for CVAR, reduced contrast volume, fewer patients were prescribed narcotics or analgesics for growing pain, and they were discharged half a day earlier than CVAR patients. And they had 2.5 times fewer serious adverse events at 1 month, and 19% more improvement in overall quality of life at 1 month follow-up. So overall, there were significant benefits that we can see as far as PVAR is concerned, but there are obviously some limitations in this trial, like in any other trial. The number of patients were relatively small, and there was a potential bias regarding the inclusion-exclusion criteria as far as accessibility for a common femoral artery access due to calcification. There was a relatively small number of female patients in the trial, and morbidly obese patients were excluded, which is kind of unfortunate because this is where you see the greatest benefits of this technique. And the trial was conducted in centers with experienced physicians. So they were very proficient in ProStar and ProGlide, as well as EVAR procedures. So we don't know how this would perform in some smaller centers. So what are the future directions? Well, percutaneous access for EVAR is now FDA approved for this particular stent graft system and has therefore become a standard of care for selected patients. There are potential significant advantages in terms of patient safety and satisfaction, obviously. Financial consideration in terms of associated costs, cost savings, and reimbursement need to be evaluated, such as CMS approval for this technique and approach, and reimbursement for the use of closure devices. Further evaluation in a more broader spectrum of patients is required for full application. Thank you very much for your attention. The next presentation will be given by Mark Eskandari, and he's going to talk on tips and tricks for successful PVAR. He's going to elaborate more on what we just mentioned.
Okay, thank you very much, and has been very nicely been outlined. I think that we're seeing more of a trend toward a percutaneous approach for endovascular aneurysm repair, both for the abdominal aorta and also the thoracic aorta. So my charge was really to talk about how to optimize the outcomes here and talk about some of the different tips and tricks that we use to facilitate the delivery of these devices. We've been fortunate, obviously, as we become more proficient with the use of these suture-mediated closure devices. We've also seen an improvement in the delivery systems for the stent grafts. They're lower profile, they have better tips that allow easy delivery into the vessels, and the hydrophilic coating. All of these things in conjunction, I think, have sort of come together to a point where this is going to be something with broader application. As a disclosure, I am a course director for the PVAR training programs. I can tell you that these are enthusiastically embraced. There's over 20 programs that have already been done within the last 4 or 5 months. We just had one at Northwestern this week. So we've heard about the advantages, and so there were the theoretic advantages of a percutaneous approach and the true advantages as we've heard through the randomized study, and these are the ones that are listed here. And as Dr. Krager has really pointed out, I think the biggest benefit comes from the heavier patients. Obviously, if you can avoid an incision in those patients, you avoid the groin complications that really clog up your clinic, and one of the things that really bother the patients afterwards and slow down the recovery. The technique is using a percutaneous closure system, the suture-mediated closure system. This is the best illustrated technique for this, and there are a variety of ways to do this. There are a number of publications that have shown the success. And again, as the delivery systems have become smaller and we've become more proficient with the devices, we've seen higher success rates published in the literature. The first technique was using the ProStar device, as illustrated here. I can tell you that this is where we started, and we also started in 1999 after your paper. And the ProStar device, I think, was a useful device, but certainly has some limitations to it. These are the different components to it. If you've ever had an opportunity to use it, you'll see that there is a steep learning curve to it. Basically, what you do is once you achieve access, and one of the things I really want to highlight, and we highlight in the courses, is really making sure that your access is in the common femoral artery. So for access, each institution does things a little bit differently. At our program, we use micropuncture technique. We use a stiff micropuncture, especially for the calcified or scarred groins. Oftentimes, we employ ultrasound guidance to make sure we're in the common femoral. But if you're to take any of these techniques, the most important one is once you have your sheath inside and before you upsize and use your closure system, really take a shot to make sure that you're in the common femoral artery. So we do an ipsilateral oblique projection, and you make sure you're below the epigastric and lateral circumflex, above the femoral bifurcation, and you're in a good segment of that common femoral artery. One of the biggest problems that we've experienced in the past are punctures that are either too high or too low. Punctures that are too high sometimes will be up in the external iliac artery and the sutures will catch the inguinal ligament. When the patients get up and move, they'll have bleeding problems. Punctures that are too low obviously cause stenosis of the SFA and profunda femoris. But in this system, what you have is a marker port. You advance this, there's a dial that allows you to dissect down to the anterior wall of the vessel, and then you have the marker lumen as illustrated here. That marker lumen lets you know that you're inside the vessel. There's a series of mechanisms that allow you then to fire needles from inside out of the vessel, and you retrieve your sutures. So the sutures come outside the skin. They're in a cross configuration. These are braided sutures. And the ProStar system comes in both an 8 and 10 French system. You can use either one. I think that the 10 is the more readily available. After you've done this and you've retrieved your sutures, the next thing you do is you tag those sutures. You've rewired through the delivery system, usually using a stiff wire, and then you can introduce your larger sheath for your stent graft system. At the end of the procedure, the thing that we've learned over the years, the most important component of this, which is relatively obvious now in retrospect, is making sure you maintain wire access. So at the end of the procedure, we use low-dose heparin for most of these cases. So at the very end of the procedure, we'll reverse the heparin, we'll pull the sheath out, maintain manual pressure into the groin, tie the knots, and then cinch them down over the knot. That way, you still maintain access. And if you have inadequate hemostasis, you still have a wire access in place. If the hemostasis is not sufficient, you can reintroduce the sheath and occlude the femoral artery, and if need be, place an additional closure system or do a cut down and repair the artery. The more recent technique is using the ProGlide system, and this is now our default mechanism in our institution. I think many institutions also use this. It's a little bit easier to use. I'm sure many of you use this in your current practice for peripheral interventions. Some of the advantages are the tip is a straight tip instead of a curved tip. It's a lower profile system. It's a monofilament suture instead of a braided suture. The suture is already made for you, so you don't even have to tie a knot. The knot's already tied for you. And the device is less expensive than the ProStar system itself. The technique here is, again, achieving access and using 2 of these closure systems on each side, especially if you're getting above a 12 French sheath. So you achieve your access in the same technique. When you introduce your system, I think I have this in the next slide. So basically what you do is once you get your ProGlide system into the artery, and you've got your marker port showing that you're inside the vessel, then you rotate it at a 10 position, deploy the sutures, retrieve it, rewire the device, introduce another ProGlide system, put that in the 2 position so that they're sort of oblique. Then you capture your sutures, rewire, and then you can go ahead with your procedure and dilate up. Oftentimes you're going from basically a 6.5 OD system to a larger system, so oftentimes I'll dilate that up sequentially by either putting an 8 in next, 8 French sheath in next, and then a 12, if need be, up to the larger size for your stent graft system. At the end of the procedure, it's the same as you do for the ProStar, so you tie down the sutures over the wire, and you can lock those sutures down. So what if you have inadequate hemostasis? Well, one of the publications that were put out back in 2008 by Dr. Anthony Lee looked at the use of an additional ProGlide system. And I could tell you in the beginning I was a little skeptical of this, but this actually has become a good salvage technique. So if you've got one good purchase with a ProGlide and the second one really hasn't provided adequate full hemostasis, the addition of a third one with manual pressure will oftentimes then get you the desired result. Again, maintaining wire access is probably the most important take-home message for this, because if you don't have the hemostasis that you like, you can just reintroduce your sheath and do a controlled cut down into the groin and repair the artery. Oftentimes the things that are asked, I would tell you that in our practice for all thoracic and abdominal aortic aneurysms, our default is that we will attempt percutaneous closure for those patients. There are a subset of patients where we will not do it, though. And so in my mind, the absolute contraindications are patients that have pre-existing common femoral artery aneurysms. These are bad problems. Oftentimes, these are thrombus-filled. The quality of the vessel is not well, and as a result, it won't hold the sutures. The other one, as outlined before, is calcification in the artery, particularly anterior wall calcification or significant posterior plaque. Those are the ones that we'll primarily do a cut down on. They're going to be difficult whether you do a cut down or percutaneous approach. Other sort of relative contraindications are patients that have bypasses originating from there, patients that have had previous femoral end arterectomies and have a patch and scar in the groin. So those are the ones that are a little bit more problematic. As we know, and we've learned this, I think, over time, that there are a number of complications in introducing some of these larger sheaths through the iliac vessels, particularly if they're heavily calcified or tortuous, as Ross showed us earlier for some of the cases. And there can be some fatal complications, and you want to avoid the picture that you see here on the board with the external iliac artery being avulsed or extravasation down in the pelvis. And unfortunately, what we're starting to see is we've learned these lessons, and as the introduction of percutaneous valves has come into play, we're starting to see that as a recurring theme again because of these stiff, higher profile systems. And primarily what you see is avulsion of the vessel as you're removing the sheath, not so much when you're taking the sheath out. And these are preventable, and as Ross outlined earlier, the most important thing is case planning. So really doing your CT scan that looks all the way down into the pelvis and down into the femoral artery. Particularly if you're interested in percutaneous PVAR, it's important to look at the quality of the common femoral artery and look at where the bifurcation is. I'll finish up just talking a little bit, one or two words on the endoconduit technique. This is a technique that allows you to pass through diseased or small external iliac arteries using a stent graft in the external iliac artery and basically performing a controlled rupture of the external iliac artery. You can see here, this is a patient who's had a previous femoral endarterectomy with a very stenotic, atretic external iliac artery. By sequentially dilating this up, then a stent graft was placed. This was dilated up and allowed an 18 French sheath to be introduced without any difficulty. And the whole thing here is to avoid avulsion of the external iliac artery. There are a number of anatomic considerations as illustrated here. The most important of which is that the common femoral artery has a good caliber. So this will be a unique subset of patients that you'll see where the common femoral is okay, but the external is a problem. And I think the most important thing are illustrated here. These are the key points. This was a publication from our institution a couple years ago. And basically it's covering from the common iliac artery all the way down to the proximal common femoral artery. So you really need to bring it all the way down. Otherwise, you'll end up with an avulsion right at the external and common femoral junction. And using the various stent graft systems, depending on the size sheath that you're going to end up putting in. So for a 22 French sheath, you need a 10 millimeter angioplasty, and for a 24 French sheath, a 12 millimeter angioplasty. Again, it's a controlled rupture. The important component here is that you've got a good external iliac or good internal iliac artery on the contralateral side, and you've got a good common femoral artery in both groins. And these are some of the different techniques. So I'll finish here. I'll just tell you that in conclusion, we see that PVAR has growing applications, and with good technique, I think it is the best approach to consider for these patients. And endoconduits may be used in a subset of patients for people with extensive external iliac artery disease. And I'll finish there. Thank you, Jaffer and Paul Jones, for the invitation.
Thanks, Mark, for such a fantastic presentation there. Just to get on with our program and just trying to stay on time here, I would like to invite our next faculty guest, Dr. Kumar, who comes from Mississippi and is a great friend of mine, and we actually met about 15 years ago, so believe it or not. Dr. Dietrich, it was at one of your courses out in Arizona, and we were in the audience and just kind of bonded a little bit, and he was the first vascular surgeon that I came into contact that probably did just as much catheter-based interventional work as I was doing, so I was quite impressed because it was a time whereby the surgical community had not quite embraced catheter-based endovascular interventions. And needless to say that Dr. Kumar is truly a talented and well-respected interventionalist from a vascular surgical perspective, not only throughout the country, but also he's lectured abroad. Vinny, you want to come up and help us out with the small abdominal aortic aneurysms? Should they be treated or not?
Thank you, Paul, for that introduction. I'm a small-town doctor. So I'm going to tackle a very interesting topic, a small abdominal aortic aneurysm. Should we wait or should we treat? And pendulum has swung in different directions, as you can see with some of the data which I'm going to show, and then we came to the conclusion, what should we do? So as we know, abdominal aortic aneurysm, a 13th leading cause of death, is predominantly seen in males. Very risky in female because high incidence of complication due to small vessels and calcified arteries. And current recommendations through the task forces have been that every aneurysm less than 5.5 centimeters in diameter should be observed. The problem with abdominal aortic aneurysm is the rupture. That's the only reason why we treat them, and a treatment can prevent them. So are we looking at prevention of these aneurysms even when they are small? So how it has evolved over a long period of time. And I tried to look at what small constitutes. So we go to Webster's dictionary, which says having comparatively little size or slight dimension. But it does not mention exactly the size. In my mind also, 5.5 centimeter size is also a misnomer because it's not true in all the patients, because there's a difference in the size. If the native aorta is 22 millimeters in diameter, sure, 5.5 centimeter aneurysm may be a small aneurysm. But if the aorta is only 15 millimeters in diameter, 5.5 constitutes a larger size of the aneurysm. So big issue is there a way of predicting in a given patient whether it's a small or large aneurysm, whether it's going to rupture or not, then decide whether we can treat them or not. So earlier data came from Ron Darling's group in 1977. They looked at 473 non-repaired abdominal aortic aneurysms at autopsy. They found 118 cases of rupture, and 13% of which were less than 5 centimeters in diameter. We looked at other report in the same data, which shows 10 to 24% of ruptured aneurysm were less than 5 centimeters in diameter. But the other side of the pendulum was also important. When they look at the autopsy report, they saw 60% of abdominal aortic aneurysm larger than 5 centimeters, and some of them up to 10 centimeters never experienced rupture. So in all, we cannot predict which aneurysm can rupture and which cannot. So believing this fact, Dr. DeBakey and his group always believed that all aneurysms, small or large, must be treated. And once I heard Dr. Stanley Crawford, who basically said, it has no business to be there, take it out. Well, ruptured small aneurysm was also discussed with the Seattle group. They looked at 161 patients with a ruptured abdominal aortic aneurysm and 11 patients with less than 5 centimeters in diameter. That constitutes 6.8% of these patients did show ruptures. And during that time, by this time, the surgical techniques have significantly improved, and they came to the conclusion that the patients are good surgical risk. Regardless of the size of the aneurysm, they should be fixed. In Annals of Surgery, Berenstein and their group showed 99 high-risk patients with 41 underwent elective repair. 34 of them died because of unrelated causes, and small aneurysms ruptured in less than 5% of cases. This is the first article which basically started telling us that let's just wait. Small size aneurysm can be watched carefully. British conducted UKSAT trial, which is UK small aneurysm trial. They looked at 93 centers, 1,276 patients, and all aneurysms larger than 5.5 centimeters were treated. Anything smaller than that were untreated and kept under surveillance with ultrasound. And they said only time to operate on these patients if aneurysms suddenly start growing larger than 1 centimeter in diameter. And their recommendation was it is safe for us to go ahead and wait on these patients as long as the aneurysm is stable. And they finally continued to enroll more patients up till about 1997 to 1999, and they looked at 2,257. Big number, 2,257 patients. And they said after 3 years, annual rate of aneurysm rupture in patients less than 5.5 centimeter size aneurysm is less than 2.2%. And they said, go ahead and observe these patients. And similar results we're seeing over the time in New England Journal of Medicine from United Kingdom as well as United States. And they basically came to the conclusion that even if we treat the small size aneurysm, survival is not improved by any means. So United States Task Force looked at all this and basically realized the aneurysm less than 3 centimeters has risk of 0%, and 5 to 5.9% is 3 to 15%, and higher we go, the number increases. Preventive Task Force basically said repeat ultrasound should be done for these patients who has got aneurysms which are smaller. They can be spaced between 3 months to 12 months, depending on the size of these aneurysms. And in JAMA, they published that we are becoming more aggressive. We are actually changing and seeing these patients every 3 or 4 months and doing ultrasound, and it's essentially not necessary. Is there a medical treatment for small aneurysm? Well, they looked at a lot of these patients in UK trial. They tried antibiotics, propanolols, simvastatins, beta blockers, ACE inhibitors. All of them demonstrated no significant benefit of medical therapy in prevention of aneurysm rupture in small or large aneurysms. So then we come down in early 1999 and 2000 when EVAR becomes important. In this era, we started to look back and say, okay, if surgical therapy is very risky, why not try endovascular therapy? In my own personal experience of 669 EVARs done over 13 years, we only had 2 intra-op deaths, 6 late deaths, 2 renal failures, and 0 limb loss, suggesting this is a relatively safe procedure and can be offered to small aneurysms. However, there was an article in JAMA which basically raised the question, if there is no significant benefit of surgical or EVAR therapy, there's no need to offer these therapy to even small aneurysms. So to date, there is only one single trial, which is called Pivotal trial. It's a multi-center, prospective, randomized trial of looking at small aneurysm, either for surgery group or a surveillance group. The operators wanted to enroll close to about 1,000 patients in this group. However, that was never achieved. And when the results came out, we basically looked at these results very carefully. But before Pivotal trial results came out, we saw this paper from Mayo Clinic, which predicted that for repairs of small aneurysm, results of EVR or open surgical repair are no different at 5 years at tertiary institution. And they think that they predict the Pivotal study will conclude EVAR is not superior for small aneurysm. And exactly that's what happened. 725 patients enrolled, 13.3% women, endovascular repair in 366 patients, 362 patient follow-up done by ultrasound, and 89% of these patients underwent surgery. At mean follow-up of 18 months, 15 deaths have occurred in each group, and aneurysm rupture or aneurysm-related deaths occur only in 2 patients. So the operators or the investigators for these groups said early treatment with endovascular repair or rigorous surveillance with selective aneurysm treatment as indicated. So both appears to be safe for patients for small aneurysm. So we can go to either therapy as needed because at 3 years interval, there's no significant difference. But then, is there a way of method of rupture assessment? We looked at some of this data coming from Canada, which said abdominal aortic wall stress, expansion rate, degree of symmetry, and presence of intraluminal thrombus and female gender are high risk. Abdominal aortic aneurysm will usually rupture when the wall stress exceeds the wall strength. And this is very important. They basically looked at necropsy and created a model. And as you can see in red areas, these are stress areas which can rupture. So preoperatively, if we can predict in a given patient by this model that these are susceptible areas, then the small aneurysm should be treated. Otherwise, small aneurysm can be left alone. The other thing I came across was a biochemical thing. They have granzyme B. The levels of this enzyme were found to be very high in aneurysm. And then the investigators said if they can reduce the level of these enzymes, they can stop the growth of the aneurysm. So far, we haven't come out with any medications which can help in this field. So to answer the question, what should we do with small aneurysm? Waiting is desired because the risk of rupture in aneurysm smaller than 5.5 centimeters is very low. Small multiple trials have shown safety of waiting in small aneurysms. Some of more recently proposed abdominal aortic aneurysm rupture risk assessment and the enzymatic reviews can be done in these patients, which will become biochemical markers in future to tell us which aneurysm is at high risk. And in future, these technologies will make a big difference. But is there a risk in waiting? I think there is a significant risk in waiting. I was talking to Dr. Krazier yesterday, who had a ruptured aneurysm 3.9 centimeters in diameter sent to him. So honestly, if we have a crystal ball by which we can look at the crystal ball and say this aneurysm is going to rupture, obviously we can treat. Data is as good as it comes, but non-availability of vascular services in underserved area and high-risk non-compliant patients, as well as females, become a cohort which need to be carefully looked at. And in my mind, 5.5 centimeter number is misnomer, especially in patients with small native aorta. Thank you.
Thanks, Vinny, for such a great presentation. And I'm just going to take 2 minutes, and I'm going to invite Mark up. But I think this is just such a interesting topic, and it's commonly, we commonly face it on a day-to-day basis. In fact, I just got a call yesterday about a similar scenario. And I just want to get an opinion from our international experts here. Vinny, these small aneurysms, women in most of these studies were underrepresented. So they kind of get clouded in terms of outcomes. You pointed to the fact that they rupture at a much smaller size in women, and also morphology, the saccular nature. We put all that together. How rigid should we really be on this fixation of 5 centimeters or 4 centimeters in a female? Should we really be treating that? I mean, should we be more aggressive in that particular population?
I think we should be. All the data, if you look at US trial as well as UK trial, they have excluded females in this surveillance group. And my feeling is females are much at high risk as compared to males. So if you see a patient who has got a major thrombus load, small aorta, and an aneurysm which is 3.5 to 4.5, my idea was to go ahead and treat them to prevent rupture.
Ted, you're all over the world.
Yeah.
Can you help us out?
I can help you out, but you hit the nail on the head, Vicky. I have a slide made up of, shows a ruler going across an aneurysm, and I say we have Homo sapiens walking on the moon, and you're using a ruler to figure out what an aneurysm is going to do. The computerized programs that are available now, the biomechanics, I'm working with a company in Belgium. It's incredible how you can follow these patients and see exactly what the stress and the pressure is. So we need to get more sophisticated. We should get rid of this idea about measuring the diameter. We need to get the computer programs that the other people have and use that, and then we'll be able to answer the question.
Vanko?
It's a very complex issue to discuss and answer, but the pivotal trial was done with a device that's obsolete, and there were problems related to it as well. So we have not tested it recently with current generation devices that are low risk. We have not done it in patients with local anesthesia and percutaneous approach, where we can do it in patients with severe comorbid conditions. So this literature of 5.5 is all based on the basis of surgical data and surgical risks. So I think it's totally obsolete. And there are several other factors that play a role, like we said, female, the size of the aorta, pulmonary hypertension, malignant hypertension, family history of rupture, all of those things play a role. So somebody should look at the meta-analysis and putting those variables in and do a statistical analysis. I can assure you can find better predictors of rupture than what we have at the present time. And the diameter is not the only one.
Thank you. Mark, one final comment?
Yeah, the only thing I would stress is basically what I think the message here is that until we have evidence-based medicine to dictate what the recommendations are, we should continue with the recommendations that are already put forth.
Okay, thank you. I'm going to move on with our agenda here, and I'd like to invite up our next faculty guest here, who again is a extremely well-respected national and even internationally renowned physician here in endovascular therapy, who many already know, Dr. Mark Muleson, comes down out of Wisconsin, Milwaukee, and to show us a case of a technology that has evolved and is evolving, and it kind of really sets the tone a little bit for one of our more controversial areas today about how do we deal with these complex necks, no neck type of aneurysms. And Mark is going to show us a case about the latest and greatest in terms of a fenestrated graft, branch graft technology for intervening on this. So Mark, without any further ado, you want to come on up and take over from here?
Thank you, Paul. I don't know if I'm going to be able to take over anything, but what I can do with you is share a case of a Cook fenestrated deployment device and its technique. As I'm sure you know, the Cook Zenith device has been recently approved for use in the United States, and it's a custom-made device. Being a custom-made device, you have to pay a lot of attention to how the fenestrations, the scallops are fitted, obviously, on the edge of the graft. The Z-fen is a tubular graft, which, similar to the Zenith device, has a suprarenal fixation wires on top of it. And then, of course, there's a second device, which is a bifurcated device that sort of fixes the aneurysm distally and treats and finishes it up. And the device is up to 36 millimeters in diameter. For 34 to 36, it's a 22 French outside diameter, or 20 French for the lesser and the smaller sizes. Now, it's important to really understand that there's a lot of markers on this device, and the first one you're going to do, you're going to get a little confused, and you have to spend a little time, if not a lot of time, trying to really understand what all these markers mean. But in a nutshell, the fenestrations themselves are fitted with 4 markers, one east, one west, one north, and one south. The scallops are fitted with 3 markers. And the orientation of the device is very critical because the patient is going to be obviously supine on the table, and you're going to be emulating a coronal cross-section of a CT scan, and the markers that will predict the orientation of the device are anterior and posterior. There are actually 4 markers anteriorly, and there are 4 markers posteriorly, so that it forms a cross, and by rotating the device and figuring out where these markers move, you can predict how to place the device fairly accurately. Now, there's a variety of trigger mechanism somewhat similar to the Zenith Cook device, except for the first release, which is the diameter reducing wire. And this diameter reducing wire is important because before its release, you can still manipulate the device, and you can still torque it, and you can still finalize your orientation. Once this wire is pulled out, it completely sort of releases the device, and the opportunity for further manipulation is significantly reduced, if not gone at all. So you have to pay a lot of attention to this particular delivery system. In terms of patient criteria, 4 millimeters is really the first variable that you want to look at because the first 3 or 4 cases you're going to be doing, Cook will not allow you to do anything more challenging than this, so that there has to be a less than 60% angulation, and the neck below the lowermost renal artery cannot be any smaller than 4 millimeters. And then there's a variety of variables that you really have to pay a lot of attention, and you have to fill out these fairly complicated forms because the forms are going to be sent to Australia, where the device is custom made and manufactured, and it takes about 4 to 6 weeks to get that device made. And you have to be, fairly conversant with Terra Recon or any other program so that you can truly spend a lot of time, just making sure that the fenestrations are radially placed where they belong. Obviously, if you don't do that right, the device is not going to be well fitted. And then 4 to 6 weeks later, the device comes to the site. And you really want to make sure that it comes actually with a bunch of photographs of the fenestrations that have been fitted. And you want to go back to your original notes and make sure that indeed, this is the right device. And of course, you have the Cook, specialty people there with you to help you make sure that all that is done. So this device requires, unfortunately, there's some lines that don't show up there, but it's okay. On the contra side, there has to be a sheath, because through that sheath, this is where you're going to be manipulating your catheters to get into the renals and place the renal stents. So once the 20 French sheath is placed contralaterally, you have to get access to at least 3 different more wires to get the 6 French sheath ready to go and ready to catheterize the lower part of the device, the Z-fen device, once it's deployed into the aorta. And this is, again, the anterior and posterior markers. You can see that they're all crimped up, and it's difficult to really see them well unless once you get comfortable where they are, then you can orient the device accordingly and make sure that it is truly in an AP position, and you don't worry too much about where the fenestrations are going to end up yet. If you orient that device appropriately anterior and posteriorly, the fenestration should really open up exactly where the renal arteries are. And once the device is deployed, then what you can do to facilitate the catheterization of the renals, you go back to your CAT scan and you figure out where did these renals come from. Like in this case, for instance, if they come a little bit anterior, a little bit posterior, you can adjust your C-arm to try to best profile the markers on the fenestration that will facilitate the angulation and the catheterization of the renal arteries. And then, of course, once they're catheterized, you want to advance your sheath distally, make sure that you are indeed in the renals. You don't want to get, the less manipulation is always best in the renal arteries to avoid trauma and dissections and whatnot. And then now the sheath are in, you're ready to advance your atrium stents, and this device, is augmented with this atrium balloon expandable covered stents. And once the stents are inside the sheath, now you are ready to dilate the device in place at the seal zone. Once that's done, you are now unsheathing the renal stents, and once they're deployed, you really have to make sure that the sheath gets back beyond the fenestrations, because you still have to flare the trailing end of the stents to fit the fenestrations and get a seal to avoid a type 3 endoleak. And then once all that is done, now you're ready for the second piece device, which pretty much deploys like a typical Zenus device. So here's the patient. Note that we've come from the left first, which is the contra side, and you can see that it's getting a little busy there in terms of all the wires. Here's the main device coming up from the right side. This was a 34 diameter, so this is a 22 French outside diameter sheath. And note that I have a pigtail up, which will allow me to puff a little contrast to determine where the renals are. At this point, you want to pay attention to the spine that I've talked about. I don't know if you can appreciate that, but at the bottom stents, the second stent down, you can see a set of markers that are vertically as well as or horizontally aligned. Now you deploy the device, see how the fenestrations opened up. Like I said, you don't want to pay too much attention at this point, but you want to pay attention on the second part of the stent where the markers predict the orientation of the device. And again, you really want to make sure that it is deployed, in the right position. Otherwise, your fenestrations are going to end up the wrong way. So the bottom part of the device is now deployed. And then what you're going to do is come from the opposite side where your sheath have been preloaded with the renal sheath and so forth. And then you get into the tube graft, and you're going to be picking the renals at this point. And the fenestration should really have opened up exactly where they're supposed to be, unless there's really a misalignment error. And you just try to see which one will take further. Here it happened the right catheter went easy through there, so we get the 6 French sheet, do the same thing on the left side. And you may want to use different catheters. Sometimes it looks easy, but it's not. And here are the stents that come in on both sides. Now you're going to unsheath the stents and deploy the stents. Make sure that you have about 3 millimeters of stent proximal to the, this is where we release the trigger. I don't know if you saw that, but at this point there was no opportunity to move anymore. So now remove the cap. Finish the deployment of the fenestrated device. dilate in place, get the seal right at the seal zone above the renals, and unsheath, obviously, the renal stents, dilate the renal stents. Have to make sure that you regain access into the stent with the sheath that I've mentioned to exchange for a larger 9-10 millimeter balloon in order to flare up the fenestration. See how you have a larger balloon here to really sort of pop that fenestration open at the seal zone. Same thing on the left side. And then once this is done, now you're going to be ready to insert the final device. And obviously, you will deploy that lower. Make sure you don't disturb the renal stents. And the final device opens up, just like the Zenith device. You're going to see the gate pop open on the left side. And then you just get your catheters and get back into the gate and finish it up, just like you would a Zenith device. And then remove all the sheath and all the get the contra limb. And by the way, all those measurements should be done ahead of time. They should be, the less guessing you have or the less troubleshooting you have at the time of deployment, I think the better off you are. And then we use a Coda balloon to dilate in place the second device and the gate. And here's the final angiogram. That's it. Thank you.
Mark, you can stay. Thanks, Mark, for that illustration and example of really where technology has come and our abilities to utilize these fenestrated grafts with this complex neck anatomy. And again, this sets the stage for, again, in these particular patients with these complex short or no necks, the value of this advanced technology and its ability to care for our patients as we compare to some of the less advanced technology and the messages we need to try and provide to our corporate partners in terms of where are they and where they need to go. Let's move on, and we'll come back to this discussion further on in the agenda this morning. But I want to begin with the other agenda items on our program here, and I guess as I'm up, looks like I'm going to be talking about the role of intravascular ultrasound in the management of patients with aortic pathology and its potential adjunct as a tool for endovascular treatment of thoracic as well as abdominal aortic aneurysm disease. Let's see if I can do this. Okay, these are my disclosures. Again, nothing that has any significant impact on this presentation, short of the fact that the folks from Volcano did provide a slide or two to help out. But again, I have no significant financial interest in that particular company. This is a device that is by Volcano, and I show this because I think there's significant improvements on some of the prior devices, and as you can see here, this is the device that we use routinely for the aortic aneurysms and aortic pathology evaluations. It is a 8.2 French catheter with a as we can see with the pointer here, there is a transducer at the tip, but what really is nice about this catheter is it has these graduated markers on there so that you can not only get the intraluminal assessment of diameter and coexisting luminal pathology, but you can actually get the length of the vessel that you're looking at, as well as the length of the pathology. So I think that's significant advances that I was certainly excited to see. This is the caliber or the type of the quality of the images that can be obtained with intravascular ultrasound. Again, it gives you a nice illustration of the ostium of various branch vessels as well as the lumen itself. At various levels of the abdominal aorta, as you can see here, it is very good in terms of pointing out pathology here. This is the renal artery here. This is the aneurysm. You can see laminated thrombus. Also, what we've seen, not uncommonly, we can see various types of debris. Sometimes it has a hinge type of shape and just flopping in the breeze there, the so-called shaggy aorta. That becomes very, very concerning for us when we're intervening on these particular types of cases. As we go up and to the thoracic aorta from an interventional perspective and repairing of these aneurysms, particularly in patients that has some renal insufficiency, it is of significant value in, again, delineating the branch vessels here, showing the ostium, and that will assist in our deployment. And as you can see here, it can be invaluable in assisting on precise deployment. At the same time, though, it can show you that on intravascular ultrasound, there's significant infolding of the graft and potentially could be a source for a type 1 endoleak. We actually saw the same value when we're utilizing IVUS in the periphery, and I know in my earlier experience with the Viabond stent graft and the SFA, looking at the IVUS and demonstrating the amount of infolding was just invaluable. And we see that same value as we look at aortic pathology as well. In light of all that, there's a lot of initial interest in utilizing IVUS as a diagnostic tool for evaluating aortic pathology, as well as an adjunct to post-interventional assessment. And as you can see here, it has been shown to be potentially interesting as a diagnostic tool for aortic dissections. The so-called shaggy aorta, we've seen these patients with blue toe syndrome or trash feet or atheroembolic shower. The IVUS actually, if you look at some of those cases, you can see a lot of atheroembolic debris that's actually quite mobile to the point where sometimes it causes you to actually back off on any type of mechanical intervention of those aortas and change your treatment strategy. Additional evaluations of the neck, as well as the proximal and distal landing zones and stent graft cases, it's been invaluable. And also, there's interest in the fact of those patients whereby the access, the iliac arteries and or common femoral arteries is of questionable patency. Doing a intravascular ultrasound evaluation in addition to evaluation by CT scan has proven or shown to be of significant value. And as I mentioned before, its role in post-graft assessment. These were all theoretical benefits that many of the operators felt that IVUS could offer. In addition to the fact that, again, we can limit contrast, reduce radiation exposure, and ultimately provide an overall benefit with reduced complications in our patients. There's published data here. There's several articles here, one of which is by Dr. Dietrich and Ramaya out of the Arizona Heart. As you can see there, they have a significant amount of experience with this in the past and with some of the earlier pioneers in promoting this particular technology, but certainly there are a number of studies supporting its role and value. And basically the general consensus and the opinions of many of these authors was such that this is truly, truly an advantageous adjunct tool as a diagnostic tool, particularly when performing endovascular repair of aortic aneurysm disease. Some advocate its routine use, and particularly in those complex cases, and it has the benefit of reducing the contrast load in those patients that has underlying renal insufficiency, cutting down on fluoro time, radiation time, and again, ultimately proving to be of value in reducing overall patient complications. So there certainly was a general consensus out there of the value of this particular diagnostic tool. I just want to share with you a couple cases whereby I've utilized the device, and I just thought that it was just invaluable as an adjunct tool to me. This is a patient who was 73 years old. He's obese. He has tobacco abuse, COPD, chronic kidney disease, so certainly contrast was a big concern, and unfortunately had an expanding infrarenal abdominal aortic aneurysm. He had a non-contrast CT that showed aneurysm that had gotten about 5.2. There was also a question of his access because he had severely calcified iliac arteries on non-contrast CT. We took him to the lab. Actually, before taking him to the lab, we had the rep from the particular vendor that we chose as a device, and the rep did his assessment, and he came back and says, "Jones, I am a little concerned about this neck. I'm not so sure we can do this case with a conventional fashion with a bifurcated endoprosthesis." And so these are his measurements, and he was very honest about it. And basically, as you can see here, if I can go back one, on these cross sections here at the level of the renal arteries, he have a measurement of about 3.2, 3.1. Then just at the lowest renal, he was about 3.47, almost 3.5. And again, he said, "I don't think this can be done." And I said, "Okay, well, let's look at some more pictures." We looked at the, again, the coronal section there, and it still turned out to be pretty big. And I said, well, let's look right below the SMA on that sagittal view there, and it actually narrows down. So we're saying maybe this cannot be done in a conventional fashion, and maybe this might be a case for a fenestrated graft or a graft with parallel grafts utilizing a snorkel technique. And so we were all prepared to go there, but before I actually committed myself, I said, let's do an intravascular ultrasound to further evaluate that neck. And lo and behold, what we found was at the level of the renal arteries, as you can see there on the right, our measurements was actually a little bit smaller, with the largest being about 30.5 millimeters, and about, to me, about a centimeter below that, we were only dilated up to about 32.5. So in light of that, I thought it was reasonable to proceed and try and do a endovascular repair without doing snorkel, and only refer to the snorkel as a bailout measure. And lo and behold, we were able to successfully perform this patient and actually seal proximally without utilizing any snorkels. I have to apologize for this image here. They gave me kind of a bad picture here, but this patient was kind of large, obese, with a long aorta with limited contrast, but there clearly was no proximal leak there. And actually, I recently saw him in the office about 4 days ago, and the 30-day CT actually shows that there was a nice seal and no endo leaks. So I've clearly changed the course of the management of this particular patient. This is another patient of a 72-year-old male who's hypertension, COPD, respiratory failure, actually presented to our emergency room with expanding 12-centimeter descending thoracic aortic aneurysm, so much so that it was compromising his underlying primary lung disease. It was intubated. He had previously been seen at an outside university, whereby he was advised to have conventional open surgery for his aortic aneurysm disease, but because they did not feel that on CT there was an adequate enough neck to actually proceed with a endovascular approach. However, because of the comorbid conditions and his high-risk operative predictability, the patient and family agreed. And when I saw him at our institution, I said, basically, we can go in and do additional diagnostic evaluation and make a decision at that point in time about his candidacy. That additional diagnostic evaluation included conventional angiography as well as intravascular ultrasound. And what we basically concluded is that there was about a 1.5 centimeter neck that was actually quite suitable to endovascular repair, at least in an attempt. And as a result, we proceeded with a percutaneous approach, and as you can see here, we were able to actually land that graft right at the ostium and take off of that common carotid artery, get a reasonable seal, but as you know, there was a significant aneurysm dilatation at the base of the subclavian, I had radial artery access ipsilaterally, and we were able to basically come in and coil off that aneurysm and actually got a nice seal of the aneurysm without an endo leak. We had a 6-month follow-up on that, and the aneurysm had shrunk down about 8.9, and at 1 year is actually down to 6.2 centimeters, and actually even shrunk further as this patient was followed out. So we had a nice result, and again, this was a situation whereby intravascular ultrasound truly had an impact and changed our management strategy. This final case I would like to share with you is a patient with a chronic type B thoracic aortic dissection that unfortunately just experienced progressive deterioration of his aorta and developed a 12-centimeter infrarenal abdominal aortic aneurysm. He had had surgical revascularization prior to this for a ruptured type B aneurysm, and was an unfortunate, very complex situation. This is the CT that we were, I'm not sure why that didn't play there, but can you get that to play back there? If you can, in the interest of time, again, he had a chronic dissection with the 12-centimeter dilatation of his infrarenal abdominal aorta with a very large aneurysm, and we were quite concerned about, obviously, his risk for rupture. We took him to the cath lab with a performing conventional angiography, and this is with the assistance of IVUS because of the challenges of trying to navigate the true lumen versus the false lumen because the dissection extended all the way down to his right external iliac artery, and you can see aneurysmal dilatation of the right common iliac artery as well. And IVUS was invaluable in helping me to actually navigate all these dissection planes and get into the true lumen. And this is IVUS as we were assessing the lumen in this patient's candidacy for an endograph. We're looking for not only the diameter of that lumen, but also, given the chronicity of this patient's dissection, there was a question about how pliable that septum or that flap was going to be and our ability to be able to actually get a graft into that, particularly if you're talking about a bifurcated graft where you want the gate to open and try and basically cannulate that contralateral gate. And as you can see here, not a whole lot of room to work with, but this image doesn't show it. There was some mobility of that septum and flap suggesting that we had some room to work with and we could expand that. And we were able to subsequently put in a bifurcated endoprosthesis with extension of the thoracic graft after surgical visceral debranching, as you can see here, and this patient actually did quite well. So again, as I can try and wrap things up here, the value of IVUS-assisted intervention, be it from a diagnostic perspective or as an adjunct to intervention, I think is truly invaluable. It has the definite capabilities of limited contrast. We've been able to do some of these endovascular cases with 30 cc's of contrast or less, and that's just for assessment of a post-intervention endo leak. Diagnostic accuracy, again, significantly improves that. And another area that I don't think we talk about a whole lot, but in terms of the post-graft deployment, sometimes we have these aorta osteocalcified lesions that's really angulated, and we put the graft in and we think we have an adequate deployment because the angiogram looks good. I've gone in and IVUS some of those, and you can see a significant kink there, and I have to go in and reinforce those with a balloon expandable stent just to minimize the risk of subacute limb closure down the road. So it has truly been an invaluable tool, in my opinion, and I think that it does have the potential of improving overall patient outcomes. So in conclusions, again, I think that I agree with all the authors of the published literature, as well as many of the comments I've heard across the country and abroad from my colleagues, that IVUS is truly an invaluable adjunct diagnostic tool in evaluating aortic pathology, and certainly in those more complex anatomy cases with TVAR, EVAR, in those patients in compromised renal function, we should really consider this as a must adjunct tool. Thank you. We're going to move on in the program here, and I would like to again invite Dr. Krazier back to the podium to talk about the various devices that's available to us and that we have access to. Vanko?
Thank you, Paul. absolutely share your views about the use of IVUS and the benefit. In my experience, the most common scenario is suboptimal CTs from the outside study, and I don't want to repeat it for one reason or the other. And you don't have to do angiography before on a routine basis, particularly in patients with compromised renal function. So I agree with your suggestions, recommendations. Here are my exclosures related to this presentation. You will see a variety of techniques and devices presented. I do not have a cookbook, which device is better than the other, but I'll show you what the current generation devices can offer. We know when we look at the historical applicability of EVAR, originally somewhere between 30 to 50% of patients were candidate for EVAR with the first generation devices due to a variety of reasons, but the most common was unfavorable neck anatomy, and you can see the reasons for it, or unfavorable access anatomy, particularly related to a large profile of the devices and lack of conformability and diameters for aneurysmal disease of the iliacs. Now, EVAR in 2013, we are now 23 years of development from the original procedure, and probably more if we include Volodos, that very few of us quote, but he was one of the first ones. He designed the device in 1983 and used it in 1987. So we have here 15 years in the United States of widespread use of a variety of devices. Now, not all of them are available at the present time for a variety of reasons, but the most common and obvious reason was that they performed suboptimally, and there were two high problems, either procedural or at follow-up with complications of a variety of types. But there are a significant number that are available at the present time. And one of the features that I already mentioned as far as the early devices are concerned, they were large in profile, up to 24 to 25 French, and even bigger as far as the OD is concerned. And there were not only large in profile, but there was an issue with trackability. Now, the newer generation devices are getting smaller and smaller and smaller, and I would not be surprised if in 5 years or so we see devices that are 10 French in profile. I know some of them that are being considered for investigation, but the current lowest profile device available is 14 French OD by Trivascular Ovation. So all current devices are lower in profile than they were originally, and they can be used via percutaneous approach, which is very important for non-surgical specialists that perform those procedures. Now, there have been tremendous improvements for the last decade and a half, as far as fixation is concerned with hooks, barbs, endo-anchors, either suprarenal or infrarenal or sealing rings, or the use of anatomical fixation, as you can see here. And the seal zone related endoleaks have decreased dramatically, as well as the migration rates, which are now less than 1% in a lot of reported studies with the newer generation devices. All devices that are currently available on the market are more conformable, which is expanding the indications for short, angulated, challenging infrarenal neck anatomy. There has been improvement in delivery system. They are more flexible. They are hydrophilically coated, which expands EVAR applications in narrowed and tortuous iliac arteries. There are a wide range of sizing configurations, all the way up to 36 millimeter in diameter. Iliac limbs are bigger also, bell-bottom in 28 millimeter in diameter when you don't have other alternatives. They're tapered or flared. You have aorta-uni-iliac converters. You have bifurcated devices of various types available by various manufacturers. And then you have devices that are easier to deploy, more accurate deployment, and options of repositioning. Like this particular device has controlled delivery system deployment. This device has a repositionable option, which is very important in challenging infrarenal neck anatomy, to treat challenging anatomies, to prevent procedural migration, and also to avoid use of aortic extensions. Now, I have listed here for you 3 to 4 different studies that have been done by manufacturers outside of the US and also here in the US. And when you look at all the issues and potential problems that occur with devices such as technical success, 30-day mortality, 1-year mortality, aneurysm rupture, conversion to surgery, type 1 and 3 endoleak, and secondary procedures, you can see that the results are truly, truly excellent with current generation devices. So what are the valuable features when selecting EVAR device nowadays? They are lower in profile, and that's what you need. Flexibility is an important thing, and hydrophilic coating is an important thing. No sheath exchanges, accurate deployment, either controlled or repositionable. They have to be conformable in challenging anatomy, and they have to have low risk of migration, and durability is an important factor. Let me give you one of the examples how I select devices. Here, this patient had a challenging access, narrow distal neck of 8 millimeters with circumferential calcification and right external iliac occlusion. So here we chose a unibody device for narrow distal aorta that performs well in this type of scenario, and you can see the final result, which can be only achieved with this particular device unless you convert it to aorta iliac with fem-fem bypass. There's another patient with severe access problems, circumferential iliac calcifications, and stenosis, chronic renal failure, non-continuous CT from the outside study. Of course, we performed IVUS to obtain meaningful information, and then performed the procedure with the use of IVUS with no contrast until the final angiogram that you can see here with 5 cc's of diluted contrast with excellent results through a 14 French sheath. Here's another very challenging infrarenal neck anatomy, basically no neck for all practical purposes. A lot of people would do a parallel stent grafts in this scenario or fenestrated grafts. Here is controlled deployment, so you know exactly, I mean, you have to be there to a millimeter to make sure that you gain as much ground as possible. And then the final result, as you can see here with excellent conformability of this particular stent graft. Here's another kind of challenging infrarenal neck anatomy, very diseased aorta, tortuosity. We missed the target deployment just below the renal artery with first attempt. We are about 1 centimeter or 12 millimeters lower than we needed to. We repositioned that device, reconstrained it, and redeployed it in a perfect position. And that really gives you a tremendous option to treat challenging patients without getting yourself in trouble. Here is another device, truly challenging anatomy, narrowing, as you can see, below this aneurysmal para-renal dilatation. And you can see how this graft conforms very well with this strata material that is separated from the stent frame. It's only sutured on the top, on the bottom, and it conforms very well to irregularities of the infrarenal neck. Here's another scenario. If I have a vasculopath with extensive distal disease of the femoral popliteals and below, I prefer this type of a device where you can use up and over technique, which is easily done with this device, like in this particular scenario, doing a CTO of the femoral, and you can see the final result, and we even have a 1-year follow-up with excellent results. And it was already mentioned, Mark Mewson mentioned about off-the-shelf fenestrated grafts that are currently available, which has helped us tremendously in juxtarenal aneurysm and thoracoabdominal aneurysm as well. And the sandwich technique, so-called Brazilian Lobato technique, has been popularized for aortoiliac and iliac aneurysms, and that technique works as well. So in conclusion, choosing the right device, when I have challenging access, I obviously go for the lowest profile device. When I have narrow distal aorta, I use unibody device. When I have an angulated neck, I will use a conformable device. When I have irregular neck, again, conformable device. Short neck, suprarenal fixation, juxtarenal aneurysm, chimney or branched endografts, iliac aneurysm, bell bottom, IBD or sandwich technique. Thrombus, I like to extend to the normal vessel and coil or sandwich. And lower extremity disease, I like to use anatomical fixation. Newer generation devices are obviously easier to use. They're lower in profile. They are more suitable for percutaneous access and repair. They are more conformable and more durable. Lower profile devices offer significant benefits to our patients as far as the access are concerned, particularly when used with PVAR. And unibody devices offer benefits in narrow distal neck and in patients that will require future lower extremity intervention. And FEVAR and CVAR is promising technology to treat short necks and juxtarenal aneurysm and to prevent type 2 endoleak. Thank you very much for your attention.
Thank you, Dr. Krazier. Again, a truly expert at managing and advising us on all the different products that are out there. Moving along in our agenda here, I would like to invite up our next faculty guest, Dr. Charles Atcher. He's a vascular surgeon out of Wisconsin, worked with Dr. Matsumura, and we're certainly honored that you to come to join us and talk to us about the management of complex necks and EVAR, particularly from a surgeon's perspective.
Good morning, and Paul, thanks a lot. I just like to say thank you for the entertainment last night at the Untitled. It's been years since I've seen mating behavior in the younger of our species. I'd forgotten how much energy it took. Let's see, let me get this. Is this the forward? Okay, great. So I'm from the University of Wisconsin. I'm a vascular surgeon. And of course, like all modern vascular surgeons, I've incorporated endovascular technology into treating patients. But what I want to do today is I have nothing to disclose. Nobody wants to pay me anything, including insurers. The agenda is to talk about managing aortic necks outside the IFU guidelines for EVAR. But I want to really give you a surgeon's, or at least my perspective, as somebody who's done over 1,000 open repairs and a few hundred EVARs and thoracoabdominals and TVARs, sort of how I approach this. And as you know, and has been made clear, and I think the last speaker really outlined technology, but the first device was flawed. It was flexible, unibody, and it failed. Deployment failed, and the graft failed, and caused a lot of trouble. The next device was better, but it had imperfections. It migrated and it was stiff, wasn't quite as good, but better than the previous one. But the number of devices we have now has exploded. And just to show you this list, the Talent, the Endurant, the Excluder C3, the PowerLink Endologics, the Zenith Flex, the Zenith Fenestrated, the AortoFix, and Trivascular, which all of these are available in the United States now, I think. But it's, what this evolution is an evolution of designing devices to treat the failures of previous devices and to treat the problems we run into, so that they still stay within the IFU of that device. So preoperative evaluation, it's important to do it very extensively and to plan these, determine the size and extent of the aneurysm, relationship of the renal arteries, quantify neck length and angulation, the aneurysms into the iliacs, identify the landing zone clearly, and think about how you're going to approach that. The proximal neck is the Achilles heel of endostent placement. The ideal proximal neck is straight, or at least less than 60 degrees. It's at least 1 to 1.5 centimeters in length, and the longer the better. It's tubular and not funnel shaped. It's not heavily calcified, and there's minimal luminal thrombus. So when I look at a case like this in a patient that had a beautiful neck, adequate landing zones, we had to obviously put a little bell bottom in one side. But when you see the finished product over here with perfect placement at the renals and long placement down to the internal the bifurcation of the iliacs for stabilization, you look at that and you say, I feel pretty good about that. What we didn't do in this patient was, let's see, how do I go back there? What we didn't do in this patient was coil the inferior mesenteric artery because there were not very many lumbars open. But in the case of a patient that has open lumbars, we may have coiled that to prevent a type 2 endoleak. But you look at that and it makes you feel good. But patients with angulated necks have problems. And the reason is because there's much greater torque on the whole graft. And it tends to cause dislodgement, not only proximally, but distally of the components. It's less likely to seal and more likely to migrate. So ways of dealing with the angulated neck. You know, I'm no expert in this, and the gentlemen up here are much more adept at this than I am. But some of the things you can do involve proximal extension cuffs and Palmaz stents. And with those, you can straighten out a neck somewhat and allow placement of the endograft more reliably. The more extension cuffs you put in proximally sometimes straightens the neck out even more, but that's one option. And sometimes you have to put a Palmaz stent in to try and secure that and to get that last bit. This was in a patient that had a 80-degree neck. I'm not sure I got the straightening out, but I got the seal that I wanted by having the extension cuffs in there proximally. I did not have to use a Palmaz stent to do this. If the proximal neck is quite long, even though it's angulated, you get a much more secure placement. It's much less likely to dislodge or torque out or transmit that distally, as in this patient who had obviously a very tortuous neck, but we just used a standard device. The wires straightened it out and the device straightened it out, but the length of the neck allowed stable placement. The quantity of thrombus that you can get away with in deploying a proximal neck, you know, it's a judgment call. If I have a neck like this, it always amazes me how the aorta remodels after a stent's placed. The ability to do that is extraordinary, and in the thoracic aorta, it's, you see these, it always amazes me. So if I have thrombus in the proximal lumen that I think is thin, the standard is less than 25% of the diameter, but it's a judgment call. And you have to determine how loose that's going to be. Are you going to embolize it? But if most of the time you can, if it's not too bad, you can get a graft in without too much trouble. The bottleneck is really, the reverse funnel is really a short neck, isn't it? But again, I found that if you can measure to the distal, if it's not too much of a reverse taper, if it's not too much of a reverse taper, you can size to the further down the funnel, and you can still get the graft to seal, even though it may be pinched a little bit at the top, and if you have to, you can dilate that or secure it. The short neck, as people have said, it's endoleak, endoleak, endoleak. And there are a variety of ways to deal with that. This is actually pictures taken. Dr. Matsumura gave me this picture. I think he borrowed the actual pictures from Dr. Lashat in making this. But it shows a snorkel and a double snorkel. This is doable. Sometimes you have to do it from brachial or axillary access. Sometimes you can do it from below, depending on the kind of graft you're putting in. but it's doable. But the modern, obvious way to do this is with a, and we're going to have a debate about that, I guess, is the fenestrated graft, which we've just started doing in the last year. And it's for juxtarenal aneurysms or aneurysms with short neck. And Mark gave a very nice demonstration of that and how they're put in. But this is a patient of ours that we treated with that. And, but again, you want the anatomy to make it work well. You want the anatomy to be good with a straight neck and not a lot of tortuosity. So what happens when the neck is too big? And this philosophically gets to actually, and somebody that does both, open, and because of my referral practice, I probably still do 40% or 30% of my aneurysms with open cases for a variety of reasons. But what we're seeing in the last few years is that we're having to do rescues more and more, where we have to take these grafts out and reconstruct them because we can't figure out an endovascular solution to preserve them. And some of it's progression of the neck, it dilates, but some of it is pushing the, pushing the IFU requirements for that. And this is an example of that. So this is somebody who had a endograft placed just 2 years previously. It was really in somebody with a thoracoabdominal aneurysm, required an open repair, which we did. But then the open repair, we got a retrograde dissection from the clamp and we had to put a TVAR in. So combined technologies to treat that. So in summary, measure, think, and plan, have complete peripheral intervention skills and tools. And it's important to have all the tools and to have a really adequate stock of them so you can have access to them at any time. And remember, open surgical repair as the primary procedure is also a solution and may be preferable to forced or exotic endovascular procedures. Thank you.
Thank you, Dr. Asher. I think that's a great talk and certainly provides the conventional surgical perspective on dealing with these complex necks and warns us about getting overzealous about catheter-based interventions here. Let's just move on to on our agenda here, and we are going to actually open up the debate that you alluded to, Dr. Asher, because the question becomes, again, with the advances in technology, with the branch grafts and the fenestrated grafts, how much have we really gained today? I unfortunately or unfortunately, depending upon how you look at it, practice in an inner city community hospital, and more often than not, we don't have access to the luxury of the advanced technology that the corporate sector releases, but yet we're faced with pathology that is just as complex, if not more in certain situations, as that seen in some of the larger academic centers. But and we also, alluding to the fact, I think that Dr. Dietrich kind of alluded to earlier today, administration is constantly getting in our business and trying to decide what we can and cannot use, and we have to be much more mindful of the economics of what we do. So the question that's on the table is, these phenomenal, great advances in fenestrated branch technology, is it really any better when it comes to one vessel, two vessel, branch, parallel graft interventions? Is that any better? I don't know the answer. And Mark, can you kind of start off and set the stage for what's out there and what we can look forward to in terms of trying to find an answer?
Thank you. So you've heard from the previous two speakers, Dr. Aker and Dr. Krajart, that there are IFUs for many of these devices. In fact, all of the devices that are approved on the market do have indication for use. And we've gone through what these are in terms of length of the neck and in terms of angulations. And as Dr. Aker has so well said, is the next generation of device is only engineered to try to fix the shortcomings of the previous devices. And true, they're getting better. Endurance now is 10 millimeters as opposed to 15 millimeters. Ovation is 7 millimeters. So clearly, the track is in the right direction. However, though, it is also known that the expanded use of infrarenal devices beyond their limits increase risks in terms of secondary interventions, i.e. higher type 1 endoleak rates, higher 30-day mortality rates also have been published. So, of course, fenestrated EVARs for juxtarenal and pararenal aneurysms have been designed to extend the benefits so that the seal zone can be elevated to the level of the superior mesenteric or even higher in certain cases. And it maintains, obviously, perfusion to the branch vessels, including most often the renal arteries. And there has been several techniques that have sort of come out of labs because of lack of existing devices, mainly snorkel and chimney techniques, and we'll say a lot more about that in just a few seconds. There's also back table fenestrations, where an existing Zenus device, for instance, can be unsheathed, and one can fabricate some on-the-table fenestrations to fit the particular anatomical challenges. And then, of course, recently we have dedicated device. There's only one currently available on the market. That's the Cook Z-Fen. The Ventana trial has been temporarily suspended in the US to re-modify and rethink their strategies about renal stent technology. And I do know that they are in dialogues with the FDA to expedite this particular process. But the bottom line is that we have one US device which is approved, and that's the Cook Zenus device. It is obviously a custom-made device, and because of that, it cannot be used in emergencies, so that's a shortcoming of the device. And we also know that about up to 30% of patients, they do not really qualify for this device either because of aortoiliac disease and tortuosity. As I've mentioned before, the device OD is 20 and 22 French. You know, it's significant for certain anatomical challenges, obviously. And patients who have inadequate seal zone, you know, neck angulations, irregular diameters around the seal zone, osteocalcifications, all these variables have really to be taken into account, and up to 30% will not fit the IFU criteria for use of this device. And plus, you know, it's time-consuming to actually plan for this. This is a laborious effort. You have to be conversant with various software programs to predict the landing zones and so forth. And as I've mentioned, it's at best, you know, tedious to do that. Then, of course, chimneys came along, and I believe Dr. Greenberg was the first author to publish about this, and it's basically the placement of a parallel stent or a stent graft adjacent to the main endograft to maintain perfusion to renal and visceral branches. It's an intentional cranial relocation of the seal zone, and it can be also used as a bailout from accidental coverage during deployment, and the procedure has been coined as SN EVAR for snorkel EVAR. And this is a case of a single snorkel. You need to have access from the brachial arteries, either little cut down or ultrasound access, depending on the size and the anatomical challenges, but many times it's fairly easy to get access into the renal artery, and then use a stent. Now, there's no consensus on what stent to use. There's been very little in terms of recommendations. Should you use a balloon expandable stent? Should you use a covered balloon expandable stent? Should you use a Vibond stent? Or there's a lot of questions that remained unanswered. And then, of course, you can also create double snorkels in more challenging necks. I particularly have been involved in a few of those, and I like to use the Vibond stent because I believe that it conforms better. There's less torque, particularly in the gutter areas, that can be also reinforced with a balloon expandable stent. Again, these are unknowns that we will hopefully try to elucidate a little bit today. And you can get a very good, satisfactory, early technical success with these procedures with the right amount of interventional effort and the team involved. And here's some data that has recently been published. This is recent, about a year old. This is Dr. Lee, where they reported on 56 snorkel grafts in 28 patients, and the technical success is high, 98%. The 30-day mortality was very decent, 7%. And the mean follow-up, though, is kind of the Achilles heel today, I think, is that we don't really have a lot of follow-up on those procedures. But in a short follow-up period, you have a very good patency. They had 7 early endoleaks, and all of them could be corrected with the secondary interventions. And they've noted also mean sag regression at the last follow-up was 7.3 millimeters without any sag increase. So as others have now reported, we can actually make the statement that, yeah, it is a good early technical technique that can be achieved in most labs with the right expertise to do this. And even more recently, there's a report, which is a review of the literature. 93 patients are included in this review. You can see that 25% have been done on an emergency basis, and 134 chimney grafts were created in those 93 patients, including most commonly the renal arteries, but also the SMA and the celiac, with a variety of stents. And again, it's an acceptable technical success, and with short-term patencies, with still a type 1 endoleak rate of 14% in this particular report. Now, more recently, this is an interesting paper here where they included and reviewed 9 patients with a technical success of 100%, but 2 late type 1 endoleaks with rupture and death. And the conclusion of these authors were that proximal type 1 endoleaks constitutes a weak point of chimney graft interventions. Increased vigilance in surveillance of such patients is warranted to prevent late aneurysm-related complications, which they've shown that there was the type 1 endoleak here is the Achilles heel. And it kind of makes sense that the remodeling, Dr. Aker has said that surgically, he's always very impressed on how the aorta remodels itself. Now the aorta is going to remodel itself with a stent graft and snorkels around it. There has to be some motion, and ultimately I think it makes sense that the risk of endoleak is significant with later surveillance. But the technique continues to evolve. This is a fascinating technical, very judicious way of providing 4 snorkels in a patient by initially placing a first tube graft with the 2 snorkels in the SMA and the celiac, and then use the initial tube graft as an anchor for the second device, which can be a Gore device or anything else, where you create snorkels as well. And this was recently published in JVS. So the proper use of chimney grafts in the US in 2013, I believe that there's a serious theoretical weakness in how this technique works in the absence of long-term data. I'm actually quoting Dr. Moulakakis from Greece, but I think that it's a valid technique. It is appropriate for patients who have comorbid burden for open repairs, where the neck morphology precludes standard devices, and where Z-fens are excluded, as I mentioned, up to 20–30% because of unfavorable and hostile proximal and distal anatomical challenges. But I believe that today in 2013 it should only be used as a bailout solutions when everything is failing, at least based on IFU recommendations. Thank you.
Thank you, Mark. So it sounds like you have the opinion that the parallel grafts or the chimney grafts at this juncture should only be used as a bailout. Noted. I'm just going to basically talk a little bit about the snorkel procedure or these parallel grafts because in our institution, a bailout might mean we don't have fenestrated grafts. Bailout might mean that this patient has such comorbid conditions that they would be too high risk for conventional surgery. So bailout may have an expanded definition, but we'll see. Let's just walk through this a little bit. And I'm going to try not to be redundant, and in the interest of time, I'm going to go through this fairly quickly. But these are my disclosures, have no impact on this content of this presentation. And just to put things into perspective a little bit, just to comment on some of the interest in an alternative to conventional surgery. And these are some of the surgical treatment concerns, although I think it's universally agreed that surgery still remains the gold standard in those patients that are reasonable operative risk. But despite that, you know, the morbidity, again, remains in double digits, and the mortality can be as high as 3% in certain populations of patients. It can actually even be much higher, and that's particularly when you talk about the octogenarian population, which we see more and more of those types of patients, and they comorbid conditions. The impact on the hospital and the healthcare system from an economic perspective, again, these folks are generally in the hospital for a reasonable period of time, oftentimes averaging about 10 days, and it could be even longer in some of the other sicker patients. So certainly there was a reason to look for an alternative treatment strategy in some of these patients. And I'm talking about the parallel grafts right now. Mark gave us a nice illustration and depiction of the fenestrated grafts and branch grafts. But again, they're not readily accessible. And certainly for some of the routine community hospitals and even some of the university hospitals, they're just not readily available. So what about parallel grafts and the so-called chimney grafts? We can call them snorkels, periscoping, whatever term you want to use, but the fact of the matter is, as you can see in this illustration, they are just basically stents, covered stents that protect the visceral vessels. But I want to focus on just the renal arteries and just the juxtarenal pathology and aortic aneurysms, which we see certainly more than our share of. Is the fenestrated branch graft really that much better than a single vessel or two vessel branched parallel graft procedure? I don't know the answer, but certainly in terms of accessibility, rather than subject our patients to excessively high-risk conventional surgery, this has been an option. And let's just look at the literature and walk through this a little bit. This is basically a quick overview of some of the studies that are out there and have been published about the chimney or the perirenal aortic pathology grafts that were treated with the snorkel technique. And as you can see in terms of the short-term outcome, as Mark, you've alluded to earlier, actually is pretty decent there in terms of the 30-day event rate of being less than 3%. Renal failure, which is always a concern, 30%, only about 3 of those, unfortunately, required permanent dialysis. Endo leak, Mark, as you alluded to, was certainly some concern, but on the short term, they're usually pretty good here. As you can see, it's in single digits. Now, what about the grafts themselves in terms of patency? And again, as you can see from some of the published literature, that the initial patency on short term is actually pretty good, almost 100% across the board. And these are some of the published trials here. I'm not going to spend a whole lot of time because Mark, you actually reported already on Jason Lee's comments and their experience out in Stanford, so I'm not going to review that. This is from Dr. Donis out of Germany, and they reported some of their earlier short-term results. Again, a relatively small sample size of 15 patients, but again, they got 100% success rate. The mean follow-up on that was actually 6.8 years, and again, they were problem with the endo leaks from an IMA that was subsequently treated. They had one graft failure at 45 days that was treated with an iliofemoral bypass. Again, their early patency rates at 6 months was actually pretty good, about 94%. Donis went on and actually recently published some intermediate term results based on CT follow-up that they had to kind of substantiate a little bit more in terms of what's the durability of this type of therapeutic intervention. And out of 124 patients that they had treated, they were able to capture about 32% of those for a 2-year follow-up. Now granted, that's a relatively small sample size of the total, but still significant, certainly something to look at. And of that, they found that 90% of those patients actually maintained successful exclusion of the aneurysms. Only about 3 patients had a type 1 endo leak, and 2 successfully were treated endovascularly, and 1 was actually monitored and continued surveillance because there was no expansion of the sac, and they did not actually have to treat anything. So they were a little bit comfortable with some of this intermediate term follow-up on this particular procedure. Obviously, the drawbacks, I think, Mark, that you had kind of alluded to earlier about the snorkel procedure, everyone gets concerned about these type 1 endo leaks from the so-called gutters, and this potentially may be actually alleviated with some of the improvements in the design of the various grafts that we have available, particularly as you look at the AFX with the graft material on the outside that actually may fill in some of those gutters. It remains to be seen if you look at some of the other technology that's coming down the pike with the Nelix device and others. So the gutter situation may potentially go away, but it's too early to say. So our excitement, you know, certainly in our institution and just in talking to others throughout the country, compared to conventional surgery, or even compared to the penetrated graft that we presently have available to us, this might be a safer procedure, certainly when compared to conventional surgery, potentially when compared to the fenestrated grafts, whereby the overall diameter of the delivery system is much larger. Certainly, procedure time is much shorter, and also we might be able to treat sicker patients because of the time element involved, also in terms of the access issues with the iliofemoral system. This results in shorter hospital stays, and as it stands today, certainly is probably cheaper than the fenestrated techniques, and again, even the conventional surgery, given the potential comorbidities and advanced length of stay. Mark, I think you alluded to some of the problems with the fenestrated device. Availability is probably the biggest thing. With that, I'm sure comes cost. Procedure time and radiation, again, usually this is takes much longer than the snorkel or the parallel graft procedures. Technically, certainly is a bit more challenging. And if you talk about the anatomy, Mark, you talked about 20–30% of those folks being excluded based on anatomy and access issues, but also if you think about the takeoff of those renal arteries, if you recall some of Mark's illustrations, the grafts are actually going more superiorly and horizontally, but if you got an inferior takeoff in those renal arteries, that can be challenging. And obviously, we're all waiting for randomized controlled trials, the profile, and also there's data to suggest if you look at the renal function down the road, that they kind of progressively deteriorate anywhere from 10 to 25% of patients. And that's potentially related to atherosclerotic disease because these are such bulky devices. So there's some concern there, although it's nice to have a fenestrated graft in theory to be available. I just want to share a couple of quick cases with you guys whereby the parallel grafts and the snorkel proved to be invaluable for taking care of our patients. It's an 84-year-old lady, had a COPD, she has coronary disease, she has hypertension, and basically came to the emergency room with a coup d'arrêt set of abdominal pain and hypotension. And basically, a CT scan revealed a ruptured pseudoaneurysm that was contained. Now, ironically, as we had our discussion earlier about the so-called small aneurysm, this patient actually had a CT scan about 4 months ago that showed a small saccular aneurysm of about 3 centimeters that, according to the guidelines, wait and see, watch, don't do anything about. And that was the situation with this lady. And unfortunately, she shows up. We take her to the angio suite, and as you can see here, she has the stenosis of the left renal artery there, but more importantly, you have this broad-based defect of the infrarenal abdominal aorta, and this is just a free-flowing rupture here that's fortunately contained with thrombus on CT scan, but clearly something of quite concern and what falls under the auspices of acute aortic syndrome that warrant urgent intervention. We basically did a snorkel procedure on there. We get bilateral femoral artery and brachial artery arterial accesses. We did not get too aggressive with increasing her blood pressure, but the occlusive balloon was certainly readily available, and we were able to actually repair her percutaneously using an aorta tube graft with active proximal fixation and snorkel grafting of the renal arteries with balloon expandable stent grafts. She was subsequently discharged home 3 days later. This is another patient. Actually, this is the first patient that I actually treated with the snorkel technique. He was an 80-year-old gentleman. He had hypertension. He had abdominal aortic aneurysm that actually was repaired endovascularly at 4 years prior to visiting me at an outside university, and on subsequent follow-up, he had a type 1 endo leak, and at that point in time, they had suggested that he go for conventional surgery, and they had quoted him an operative mortality of about 12% actually, and he came to me actually in tears to see if I had anything else I can do to help him. I had actually taken care of his wife when I was a cardiology fellow, and on the transplant service, and he had remembered me, and he came over to ask me for some help. And so I studied his films and studied his film. I said, well, this is before snorkel and everything became popular. And I said, I have something I can try. I can't guarantee you, but let's give it a shot before we subject you to a 12% operative mortality surgical procedure. And as you can see here from the angio, the graft had actually migrated down, which was not uncommon back in those days with this particular device. So we had a type 1 endo leak that you can kind of see a little of extravasation of the contrast outside of the graft on the lateral projection there. I was able to go in with an aortic cuff with 2 covered stents, as you can see there with the snorkel procedure, and we're able to actually successfully repair that. And he is actually about 5 years out, and that graft continues to be intact. It was proved to be a very, very durable procedure for him, and he's had no further interventions required, and actually moved to Arizona for retirement. So he might be your neighbor, Ted. Despite all the concerns about, I think, snorkel EVAR, I think given the present climate of things, some of its advantages is that, the technology is something that we can readily utilize with the catheters and guide wires and stents that we're used to. It's a relatively short procedure time. The low profile of the devices that we have access to now affords us the opportunity to treat actually a lot of different types of patients, particularly with complex access issues, and that gives rise to the fact of its deliverability and flexibility as well. And I think relatively for this particular pathology, the cost would certainly be in favor of a parallel graft. So in conclusion, I think, although, Mark, I don't disagree with you, I can't deny that, conventional surgery is gold standard, but some of these patients, I think it remains a viable treatment option, particularly for the high-risk juxtarenal aneurysms. And in certain situations, as it stands today, I think the message we need to get back to the vendors in our corporate sector is that they got a little bit more work to do in this space, because I think it might be preferred over EVAR in the population of patients where we're only dealing with 1 or 2 vessels and these juxtarenal aneurysms that require protection. So I'm going to open up to our experts here again to give some final comment before we move on. Ted, you want to comment?
Well, I enjoyed these presentations and the discussion, and I think you've sort of hit the nail on the head when you talk about the community hospital. And the more I see this worldwide, and the more literature I review, and the more articles we have coming into our journal, I am more and more convinced that for the most sophisticated aneurysms where you need to treat with fenestrations, these probably need to go to centers that have a lot of experience. Nobody is going to match Roy Greenberg's data. I think we need to look, and you know, we learned this a long time ago. We learned this in coronary bypass surgery, didn't we? We've said if you're going to do coronary bypass surgery, you need to send it into the institution. Eventually, it got to the community hospital. So I think that your approach for juxtarenals using one of the CHIMPS techniques is justifiable and correct. And at the same time, I think Mark is right in that he's in a program where he has all kinds of personnel, a lot of support, and can achieve very high results. So somebody said there are a lot of unknowns. I think you said that. There are a lot of unknowns, and I think we're just at a stage where we don't have the final answer to this. So in the meantime, I think some temporary channeling of the patients in the right direction is the thing to do.
Thanks, Ted. And that sounds like a perfect answer, but the real world is, where's Bob Gadger, who is an esteemed colleague of mine, a CVT surgeon, has been around doing probably more aneurysms than anybody in Chicago. How many times we send patients to Roy Greenberg and he says, we don't take public aid?
I didn't hear the question.
Who's going to pay for it? Because we send these patients to these centers and they say thanks but no thanks because they can't pay. And we don't take the Illinois public aid or the state insurance, so no one wants to take care of these patients. And so we're stuck with them. Well,
I made a mistake in talking about the community hospital. Look, this guy out here has been to every single course we've had in Phoenix since the beginning, and I'm sure he can do anything you need to have him do. So I apologize for that community hospital. I'm sorry, Bob.
So some of the community hospitals have to step up, fortunately or unfortunately, to be able to bring this technology and these types of programs to those patients that unfortunately can't get to the Roy Greenbergs or the Cleveland Clinics or the Arizona Hearts, because the reality is they can't get there. So I think that's the real world, and we have to, I think, as clinicians, assume some responsibility for that, which is one of the reasons that Bob Gadger and I have kind of stayed and planted 2 feet in a community hospital so that these patients can get access to some of this type of therapy and get treated properly. But anyway, any other comments? Mark?
Just, you know, I think you've seen from this that life is an evolution, and the evolution is gradual and sometimes dramatic, but the key is to sort of keep aware of it. And that you don't necessarily, you have to sort of weigh the old and the new, and you don't need to be, I think these techniques we've talked about are pretty safe and pretty useful in especially acute situations where you're not going to have access to a fenestrated graft because that takes a while to make. But you have to visualize the operation. You have to visualize the procedure in a way that you are convinced that it's going to work. It doesn't do any good to offer somebody something that you really can't visualize is going to work. And we commonly see patients who they said, you know, their initial treatment was, well, you know, this may not work, but that's all we have, but we think you're too sick to do anything else. Well, to do a procedure that doesn't work, it doesn't make any difference whether they could tolerate it or not. You know, we use chimneys and it works, and it bails us out. It can be very helpful. And we use fenestrated grafts, and they work, and they will evolve.
Mark, you got any final comments?
Yeah, I think we've gone through the pros and the cons, and what I'm going to do for you, Paul, I'm going to call the district manager from Cook in person, and I'm going to make sure you get the device so you can use it judiciously in your box of tools.
All right, thank you. Let's just move on here. We got a case that we're going to show right after our next presentation here, but we got Dr. Ree, who's come all the way from Brooklyn, New York. He's chief of vascular surgery and director of the Maimonides Aortic Disease Center in Brooklyn. So he was here with us last year, and we certainly welcome him back. And while we gear up for our live case shortly, I want to see if Dr. Ree can just help us out and talk about internal iliac artery aneurysms.
Thank you. It's pronounced Maimonides, but half the people in the hospital can't pronounce it either, so you can just call it
apologize.
We're going to shift gears a little bit, and before I start my talk, I do want to emphasize all this talk about short necks and juxtarenal aneurysms are really, you can't compare apples to oranges because, the seminal paper this year at the Society for Vascular Surgery looked exactly at that concept, meaning they did case-matched cohorts from France, from Jean-Pierre Beckman, who's been doing fenestrated grafts ever since it's been available, and they case-matched it with a Mass General experience, and for regular risk, low-risk patients, it's still not the way to go. It was clearly had a higher mortality and morbidity than the standard open repair. Having said that, it's sort of the same situation for internal iliac artery aneurysm. It's very complicated. It requires fairly significant surgical and endovascular skills, and there's multiple options, obviously. The issue really becomes, can we sacrifice this sort of annoying artery? Because if we could, then we can do just about any EVAR, because access really is not an issue in 2013, as Dr. Eskandari pointed out earlier. I mean, you can do endoconduits, you can pretty much place any device through an occluded iliac. The problem is, when you sacrifice it, you're going to get these symptoms: claudication, colon ischemia. If you do enough of these, you'll see all or most of these complications, including death and buttock necrosis. If you've ever seen buttock necrosis after intentional iliac artery, internal iliac artery occlusion, you don't want to ever see that again. So the options are really open repair, hybrid repair, endovascular repair. And the endovascular repair comes down to whether or not you're going to sacrifice one or more of these internal iliac arteries. Again, gold standard is still the open operation for regular risk, but what if the patient can't have surgery or refuses surgery? So it all comes back to what Dr. Jones alluded to. You have to do what you can with what you have today, as Teddy Roosevelt says. This is our aortic center, and we pretty much do the whole gamut of the therapies, and this is option 2, which has been used and time-tested endovascular technique where you have some sort of a problem with the internal iliac system. You put an aorta uni-iliac device in and then occlude the other side and either do a retrograde or some type of an occlusive procedure, and then you do a fem-fem. But that's kind of an outdated method. There are other endovascular options, including fenestrated and branch grafts that are being tested by various companies. Cook and Gore are in the middle of trials. Actually, Gore is just starting the devices, but really nothing has been approved. Complex EVAR with this type of imaging is absolutely mandatory because basically it requires so much dye, you really don't want to deploy these grafts unless you have fairly extensive three-dimensional imaging. And you want to preserve at least one internal iliac artery unless there's bilateral problems. And I looked back at the literature, and actually this is still the largest series, the one that we reported in 2002 from UPMC when I was in Pittsburgh, of 49 patients. And we stated, we were haphazardly really occluding both internal iliac arteries at the same setting, and we found that really at that time you have to revascularize one of the internal iliac arteries if it's not aneurysmal. And this is that original series, and you can see we did bilateral internal iliac arteries on 6 patients, and we occluded them with a variety of techniques, including coils, amplets, or plugs, etc. Now we have these retractable coils, which are very convenient for this use. The rationale for stage coiling, a lot of people say, well, if you have internal iliac artery issues, you should bring them back, stage coil them, do one, maybe do both, and do an EVAR in another setting. But there's really no data showing that it's any better than doing them at the same time. Of course, it increases hospital and physician reimbursement, but that's really not the issue here. But the real concept is that can you sacrifice these iliac arteries, these internal iliac arteries, namely. And when you have a patient like this, you are most likely going to sacrifice one because doing double sandwiches or doing double bypasses is just too painful. We started to do some of them, but generally you're going to sacrifice one and try to preserve the other in some sort of way. If you have one, it's not a problem. The surgical way to do this is to do a retrograde bypass. This can be done by placing a PTFE graft or Dacron graft in a retrograde fashion to the internal iliac artery. Again, this is very similar to doing a conduit, except a little bit more painful to do surgically. But it's actually a very good way to do it. For the original study, there was a follow-up of 141 days, which is not a lot, but it was a reasonable follow-up at that time. And if you're going to get a complication, you're going to get it within 30 to 60 days. And all 49 patients survived, including the patient with the buttock necrosis. And all the bypasses were patent, including the retrograde bypasses and the Viabons that were used. As you can see by this diagram, we had buttock necrosis in 2 of the 49 patients, which was significant. And this is the algorithm, which I'm not going to go through, but essentially it showed that if you do sacrifice both internal iliac arteries, you have to make every effort to revascularize one of them, and if you're going to extend the endovascular device down there. I mean, this is very basic knowledge, but this has been time-tested over and over again in the recent literature. This is a series from 2012. It states that embolization of the one internal iliac artery is safe in the short and midterm, and this one from 2013 from Korea again showed the same thing. Repeatedly, if you do both, these patients have significant problems, including a 36% complication rate. So how to preserve, and I think this is going to be talked about a little bit later, so I'm not going to spend a whole lot of time. The sandwich technique is a technique that Dr. Lobato introduced back in 2012, showing that you can actually deploy these devices within the device to preserve the anatomy and make sure that you have 3-dimensional availability, so you're visualizing it, and actually consider using a Dyna-CT during the deployment so that you minimize the contrast, because these devices have to be really deployed perfectly, and this is a typical angiogram. You can do this with just about any device. We've done it with Endologics, Endurant, Gore, Excluder. Any device will accept a so-called sandwich, and you can use the Viabon device or even the Fluency device for the extension grafts. We generally, this is a little bloody. My fellow took these pictures and he didn't take the blood out, but I generally do a small axillary cut down for the access from above, whether it's a chimney or a sandwich, and I just put in tandem sheets, and we do percutaneous access for the femorals. And this is one we did a couple of weeks ago where we can, you can see the device being deployed from above, and this is a video, and you can see this device being deployed. You can see it goes all over the place because of the torque, so you want to be well within the internal iliac system when you do this. You can also do this with the Endologics device from the transfemoral approach in a sandwich. So there's really all different ways to do this. The sandwich technique is very valuable and is similar to the chimney techniques until the branch grafts are readily available, it is a very adequate way to preserve one iliac artery. This patient had bilateral internal iliac artery aneurysms, and we're able to preserve one. And one quick note is that even if you have a lot of thrombus, these sandwich grafts appear to have reasonable seal even within the thrombus if they're internal iliac artery aneurysm, like in this particular patient. And this is Peter Lin's picture where you put two Viabon stent grafts in a tube, and this is what they look like once they are placed within the limb of one of the endografts. So what is the future? Well, we already saw what the future is. The future really is a branched iliac artery device. This is the Gore device that's just going into trials right now, and it's deployed by snaring the counter end, contralateral end, and deploying a sort of a mini body within the iliac artery, and placing the device within the device. Very similar to a sandwich technique and a branch system. And this is the Cook device, and I placed a couple of these devices when I was in Pittsburgh, and this works in a very similar fashion. So in conclusion, EVAR, definitely endovascular options are clearly available for dealing with even the most complex internal iliac artery aneurysms. It can be performed in most cases. Unilateral coverage is relatively well tolerated, but not always. But you should always, if you can preserve it, whether you have the energy or the desire to do a sandwich, currently I would strongly encourage it if you can. Claudication symptoms are usually temporary, but not always. Bilateral coverage should be avoided at all costs. Internal iliac artery reconstruction with a bypass is very durable and should be considered in situations where the tortuosity or the anatomy disallows the sandwich techniques. And sandwich techniques are certainly possible in most anatomic situations. And again, a direct open repair for low-risk patients is still the gold standard. And many of these patients do great because you can just sew the graft right onto the hypogastric artery, distal portion of it after the aneurysm. And branch graft trials are ongoing. Thank you.
Thanks a lot, Dr. Reed. We're going to move on to jump fast forward this a little bit so that we can actually have an opportunity to look at a live pre-recorded case at this point in time, and then we'll come back to some of the other lectures. So can we get that recording going? This is a case that, again, I was involved in doing.
This is Dr. Paul Jones. I'm an interventional cardiologist here at Mercy Hospital in Chicago, Illinois. And we have a very interesting and yet challenging case here today that we'd like to share with you. This is a 80-year-old gentleman who has a history of coronary artery disease, who underwent aortic coronary bypass graft surgery approximately 4 years ago, who also has systemic hypertension, chronic kidney disease, and unfortunately, an expanding infrarenal abdominal aortic aneurysm. Here I would like to share with you a non-contrast CT scan. First of all, if we look at the juxtarenal portion of this aneurysm, as you can see, there's essentially no neck here at the level of the renal arteries. And in fact, the measurement here was reported as approximately 3.6 centimeters in diameter. As we move on distally here, as you can see, scrolling through, the aneurysm dilates out, and this was measured to be approximately 5.4 centimeters and was shown to be expanding on serial evaluations over the past 6 months. And as we move down into the iliac system, you have some ectasia of the right common iliac artery, which is not very problematic or concerning, but yet as we move down into the external iliac artery here on the left side here, and I'm going to just pan up a bit. We're quite concerned, but there appears to be a focal area of concentric calcification here, and the luminal diameter here is only about 4.4 millimeters measured on CT scan on cross-section. I am hoping when we go in to look at this at fluoroscopy that this is a bare metal stent that we can actually expand and get through this, but we might have to deal with this as we go in. Another interesting aspect of this case that is of note is on the sagittal views here. We can look at the visceral circulation and we realize that the celiac artery had significant amount of calcification at its ostium. Not sure of the hemodynamic significance of that stenosis, but as we move into the superior mesenteric artery, this looks pretty impressive to me, and I am concerned that we might need to intervene on the superior mesenteric artery as well. So we would be looking at that as we proceed with this case moving forward. Plan with this particular case, in light of the patient's advanced age, his comorbid conditions, rather than proceed with an open surgical repair, we thought that this patient might be best suited with a endovascular treatment strategy utilizing the snorkel technique, whereby we basically protect and preserve our renal arteries.
I'm Dr. Paul Jones at Mercy Hospital here in Chicago, interventional cardiologist, along with my colleague, Dr. Robert Gazier. So we've gotten our access here. We have an 18 French in the right groin, a 12 French sheath in the left groin. I also have bilateral brachial arterial access, and we began to proceed with this procedure with the intentions of probably being successful with an endovascular repair utilizing the snorkel technique in light of the fact that we essentially have no neck here. And this is our first subtraction angiography, just a hand injection to try and minimize contrast. And lo and behold, we find that there is critical stenosis of the left renal artery, as well as if we look at the screen above, there's also significant disease of the right renal artery. So this patient again has significant amount of visceral obstructive atherosclerotic disease, and certainly this bilateral severe renal artery stenosis could explain some of his systemic hypertension and probable underlying chronic kidney disease. We discovered here that, again, from a brachial approach with selective cannulation of that superior mesenteric artery, the ostium of that vessel certainly is not normal, and we're concerned about that being quite significant, and we actually did a gradient across that. It was about a 40 millimeter mercury gradient, so we subsequently treated this with a bare metal stent prior to any further interventions. And we are now at a point in time whereby we have accessed our renal arteries bilaterally, as you can see here, on fluoroscopy. From a brachial approach, we have 7 French 90 centimeter sheaths in place again via the right and left brachial artery. We have guide wires in both the right and left renal arteries, and we have a 7 millimeter balloon that we are passing into and over the wire, the right renal artery for balloon dilatation, as well as proceeding with the balloon dilatation of the left renal artery prior to putting in our covered stents. And I'm a fan of utilizing the balloon expandable covered stents by Arterial stents. So anyway, this is where we are right now, and so we're going to proceed with the balloon dilatation. I've chosen a 7 by 2 millimeter balloon. This is a pretty tight lesion, so I'm going to switch over to a 018 system. So we have a 018 wire across the lesion, and I'm going in with a 6 by 4 balloon for pre-dilatation, as you can see here, prior to passing our atrial stent. Fairly tight stenosis there. I'm going to come back a little bit. Again, I'm trying to minimize my contrast in light of this chronic kidney disease here. Again, you can clearly see the waist there. Don't count the first one. And we're going to fully dilate that. And I think that's an adequate pre-dilatation here. I'm just going to store that. Floral safe, please. And we're going to come down and try and get that sheath ideally into that renal artery, but we've had our challenges. The sheath just doesn't track so well around the arch there. Okay, well, let's just switch to an 035 system. And again, I think it's important to have a very supportive wire when you're using the ICAS or the atrial stents. All right, so I'm going to go in with my ICAS stents now. And I've chosen a 6x38. And while they're preparing that, I'm going to pretty much apply the same techniques to the right renal artery with pre-dilatation, the 6mm balloon, followed by a 6x38 ICAS. So basically what we have here, again, we put a bare metal stent into the SMA because of the proximal stenosis. We now have the 7 French 90cm sheaths into the proximal portions of the renal arteries bilaterally with ICAS or the atrium covered, balloon expandable covered stents into the renal arteries after doing adequate pre-dilatation with balloon angioplasty. Now, before we actually deploy these ICAS stents, I like to get my graft in and basically secure that and begin with the repair and exclusion of the aneurysms. And so once again, we have decided to select for this particular case, the Gore excluder. Imagine 35mm in diameter at the neck, 18 centimeters long, and 14mm in diameter for the iliac, 14.5 actually. So we're going to go in with that device through an 18 French sheath. We have prepared this artery with the pre-closed technique, and hopefully this all can be done percutaneously. Now obviously we have to kind of have some idea of where the SMA is. So I'm going to look laterally here, really mac up and hopefully use my bare metal stent as a marker. And as you can see there, I'm a little high with my endograft, so I'm going to come back a little bit because again, I don't want to compromise that SMA. And I think right here should be adequate. Let's take a picture there. So I think that looks pretty good. And again, I'm always of the opinion that when we snorkel, we want to have about a ½ centimeter of the stents that are in the renal arteries and protecting them above the endograft itself, and I think that's the general consensus. So this looks like it's lining up pretty good to me. Go back AP here. And I'm just going to use a little of my dye here just to get an idea what I got here. Subtraction, please. And I think that's kind of lining up pretty good. Jeff, what do you think? Bob? We're all on the same page here? So I'm going to commit myself here. And I'm going to deploy this in a conventional anatomic way, so I'm turning. I'm trying to get it a little bit more anatomic. So I'm going to start deploying here. Now, I'm not fully committed myself. I still can adjust this graft. Again, all the advances of the excluder here. So that looks like it's lined up pretty good there. In reference to the SMA. Again, let's get this parallax out. Again, even with the parallax out, I think you can see that the proximal portion of that SMA stent, as well as the ICAS stents in the right and left renal arteries, are well above our graft. I think we're probably okay here. So I'm going to go ahead and commit. So I'm going to secure my graft position. So that should anchor that graft into place. And now I am going to cannulate my gate. So this gives us some idea of the size of the length of the contralateral limb. But I'm going in here with a reliant boom just to touch things up. Being cognizant not to compromise my stent and the SMA. And I'm just going to do a little test injection here just to see how we're looking. Okay, I'm going to go ahead and commit after that. I'm pretty happy. So I'm going to pull my sheets back here. And again, make sure I keep about a ½ centimeter above the graft, and I think we're okay here. I think we have the lesion covered. And this will foreshorten some, so we have to be careful about that. On this side, I think we're going to do the same thing. We're going to pull our sheets back. And I think we are in a decent position there. I'm just going to look at a lateral projection here. Non-subtraction, please. And again, as you can see, that the graft is just below, about a ½ centimeter below that SMA stent. So I think we're looking at pretty good here. So I am going to commit. 14. Now some advocate at the same time of deploying the stents, going up with the balloon to dilate the aorta simultaneously. I'm not so sure if that buys me a whole lot, to be honest with you. But so this is our final shot here, and as you can see here, we have successfully excluded the aneurysm. You see some bowel there in the background, I think, filling, but I don't see any significant endoleak here. And we also have good flow to both the right as well as the left renal arteries. We did a lateral image here to make sure we had adequate flow to the SMA and the visceral circulation. As you can see here, the SMA remains widely patent, and also you can see again, adequate flow to both the right and left renal arteries. I think we got a successful result here, and I expect that this should be a durable outcome for this patient. So we're just going to close the groins and apply pressure, and we'll get back to the rest of the meeting. Thank you.
Just as a quick follow-up, that patient actually went home 2 days later with a serum creatinine of 1.9, which was significant improvement from his initial presentation. Any quick questions, comments on that case? I'm sure there's probably 1,000. So, Mark?
No, just one quick comment about your technique. That was really well done, by the way. I tend to do a kissing balloon when the big balloon goes up in the aorta, I actually inflate the balloons of the stents at the same time. To me, it may actually maybe minimize the gutter effect and get a better seal. That's one comment. I wonder if you have anything to say about that. And then the second one is once the top of the graft is deployed, I finish it up with the snorkels before I even get the gate. The reason for that is that I'm like you. I have my 2 6 French sheath in the renal arteries, and it minimizes the potential ischemic time in the kidneys. I don't know if you have any comments about that either.
So you blow up 3 balloons at once?
Correct.
Versus?
Versus you doing the first aortic balloon and then coming back and finishing it up with the 2 snorkels. I do the snorkels and the balloon in the aorta simultaneously.
I've seen that, and I hear you. Not opposed to it, but...
I mean, it's easy to
I hear
do.
you. Ted?
How did you select your abdominal prosthetic? You used the excluder here.
So if the question is, which graft did I select and why?
Yeah.
That's a good question.
I know which one you did, but I want to know why.
Well, there's a couple of reasons. One, certainly in my experience, as I showed you, that very, very first case was with an aortic excluder by Gore because of the fabric. It tends to be a little bit more compliant. I like the active fixation of the hooks there. They're not the big bulky hooks that can potentially get in the way of my renal stents. So I like the fact that, again, you got the tiny hooks with active fixation, and you don't have a lot of metal that, again, potentially could get away and distort the renal stents.
There's actually a paper that was just recently published where they did in vitro analysis of a variety of stent grafts, including Zenith, the Gore device, the C3 device, and a variety of stents. And the best combination was actually Viabond and the Gore device.
I know my chief would have a comment.
Excellent case. I agree with Mark. I prefer to do all 3 at the same time. What happens if you would have used, for instance, Viaband, what has happened to me is if you deploy the excluder first, those anchors can get into your Viaband, and you try to pull the string on a Viaband, you cannot deploy it. And you get stuck there, which is a serious headache. So that can happen. It doesn't happen always, but it happens sometimes that those anchors will actually penetrate through your Viaband and block that deployment system, and that's a problem. So that's why I like to do it all at the same time. If you're using Viaband, it might be different with ICAS because it has more radial force and it's easily inflatable. However, there is a theoretical possibility that the anchor could go through it and rupture your balloon while you're inflating it. That's another possibility.
All that's noted. Ideally, what I like to do is actually keep my graft inside the sheath and have the sheaths actually within the renal artery when I actually deploy the graft to minimize some of that trauma, potential trauma, to the graft. And also the reason why I'm biased towards the ICAS or the balloon expandable stent, because to me, you get much more superior radial hoop strength, and that's a much more durable stent than the Viabond as well.
Does the takeoff of the SMA affect your choice of chimneys?
Does the takeoff of the SMA affect my choice of treatment from which perspective now?
From using chimneys.
In this particular case, no, it does not. I think that my biggest concern about the SMA, the celiac, and that particular pathology was what would be my risk of visceral ischemia peri-procedurally and post-procedurally, because that portion of the aorta really did not have any significant aneurysmal disease, so I was able to stay away from that per se. But I was concerned about concomitant visceral ischemia peri-procedurally. That was my reason for it.
Because if the SMA takes off, say, 1 centimeter above the renal arteries, you cannot predict how your chimneys will open. You know, everybody likes to see them open at the lateral walls of the aorta, but your chimneys can stand one across the other, and may at times block the SMA. So is the SMA factor critical in the use of chimney grafts.
Right. And that's why, again, if you saw me really
This
being...
particular case.
Yeah.
This case was excellently done, beautifully done.
Yeah, but just to comment on that, I hear you. And that's why in this particular case, I was so critical at looking at that suprarenal neck in terms of its association with the SMA to make sure that the length of the graft material that come out of my renal artery stents really was not getting into the territory of compromising the SMA. But I hear you when you try and take up the parallel grafts beyond the SMA. You got to be very cognizant of that. And that's why, again, when you get into doing more than one vessel with parallel grafts, I think you're kind of really kind of going out to an area whereby, you know, I'm not so sure of the real benefits of that.
No, good case.
Any other final comments, Dr. Ree? Anyone?
I have just one comment about location of those chimneys. I noticed that you used the C3 device. A couple of times I didn't like the way the Viabonds were laying, so you can actually manipulate the C3 device either up or down to actually move the location of the chimneys so that if you deploy it in a certain angle, it will push the chimneys at against the lateral wall. Usually, my chimneys usually come down posteriorly and they come out kind of together. But if they one time they deployed anteriorly as it was alluded to before, and you can actually change the orientation by just moving the graft up and down and possibly torquing the sheath.
Yeah, those are good comments. Unfortunately, the ICAS are much more rigid stents, and to change the angulation and the orientation of that, oftentimes what you have to do is actually put a bend in your wire. You know, they're not as conformable per se. But those are good comments. If there's no other final comments, we're going to move on to the next talk here right before the lunch break, and we might have to move the other talks to the afternoon. But let's see, we're up with Mark Escandari, are you around? Oh, here you go. Can you talk to us about when all this stuff fails, what do we do? And how do we salvage?
Do you have the other presentation loaded there?
So the next topic that we have, we're going to do in the afternoon in the interest of time so that we can get to our lunch symposium. All right, Mark, you're on.
Okay. Well, I don't want to stand in the way of lunch, so I'll try to go through this quickly. My disclosures. We've heard a lot already today. I think everybody in the audience knows the advantages of EVAR as listed here. And the primary goal, obviously, is to increase the survival for patients and prevent aneurysm rupture. And what we'd like to see is that the aneurysm sac starts to shrink down over time, and that's really a surrogate that we've had improvement in excluding the aneurysm. And as we've talked about earlier today, the growing applications of these devices. But there are a number of late complications. And I spoke with Ross earlier this morning. He's also talking about some of the problems associated with EVAR. There may be a little bit of overlap, but my primary focus is on the late complications, most notably endoleaks, which are the most common complications. But sometimes you'll see cases of migration, as you see with this particular device, late aneurysm rupture, usually from failure to the device in some capacity, limb occlusion, and the devastating complication, which is fortunately very uncommon, which is infection of the stent graft, and how do you deal with those? So on cross-sectional imaging or ultrasound or whatever test you use for surveillance, the whole idea is to see that there's flow in the stent graft and not in the aneurysm sac itself. If there is, that's defined as an endoleak. We know the different types of endoleaks, and so I'll just briefly go through these types. I'll show you a cartoon of each of these and then some illustrative cases. So the proximal type 1A endoleaks are the ones we've talked about quite a bit for the complex aortic neck anatomy. And this readily represents an incomplete exclusion of the aneurysm, pressurized blood flow into the aneurysm sac, and the type 1B endoleaks are the ones at the bottom. And we've learned over time that it's very important to extend your limbs all the way down to the iliac bifurcation, because these patients have a systemic disease process where Although they may have an aortic aneurysm as their original presentation, they are bound to develop iliac aneurysms over time. And if you don't extend all the way down to the iliac bifurcation, they will develop late type 1B endoleaks. As Dr. Aker talked about earlier today, these complex necks, these are the types of problems that you can see. And what I really want to drive home is the point for this presentation is following the instructions for use. We're going to hear a lot about this for the next debate as well. And I hope that that's the take-home message, that many of these late failures are because these are the types of things that were treated outside the instructions for use. This is what these, beyond what these devices were intended for. And as you can predict in the long term, they're going to have problems. Although short term, they may have good outcomes. This is one such case where there's migration. And when you look at these films, it's clear that this is not a patient that's a candidate for a routine infrarenal aneurysm. It was salvaged with a palmaz and extension up to the renal arteries. And these are, fortunately, you'll have a pretty rapid response, and these can seal the leak quite adequately on follow-up imaging, as we see here. The type 1B endoleaks, if you look at a lot of the publications and literature now, these are patients that have type 2 endoleaks with sac enlargements, and when you do additional imaging, whether it's angiographic imaging or additional imaging to look at the potential sources for the sac enlargement, more often than not, it's a problem at the seal zone at the bottom than the actual type 2 endoleak that's been there all along. And this very simply requires extension down to the iliac bifurcation. As we heard about earlier by Dr. Ree, there are different options of dealing with the iliac aneurysms. You can extend down and cover one internal iliac artery. You can do the flank incision and bypass. There's branch techniques. So there's a whole host of techniques for dealing with this. The underlying theme here is that most of these can be treated with endoluminal interventions as opposed to open surgery. Type 2 endoleaks, we'll hear a lot about this afternoon. There are different techniques in managing these, but these basically represent backbleeding of branch vessels, typically the lumbar vessels, but occasionally the IMA or the internal iliac artery if you cover without coiling. And there are various treatment options, so I don't want to steal the thunder for the presentation of this afternoon, but these are the endovascular approaches that have been discussed: transarterial through a femoral approach, translumbar, or more recently the transcaval approach. To really take care of these type 2 endoleaks. My word of caution for type 2 endoleaks is when you seal them, make sure you put a dense coil pack in there. This is one such example where a coiling was placed in a iliolumbar vessel. You can see on follow-up imaging that the sac has grown in this patient. You can see very nicely there's contrast flowing through the coils themselves, and using a microcatheter going through the coils, which actually pass quite easily, we're able to get into the aneurysm sac. You can see the contrast in the aneurysm sac. So the take-home point here is make sure that the coil pack that you put in is a dense coil pack, not just a few coils. Transcaval, hopefully we'll talk a little bit about this afternoon, but I think this is an innovative approach. It's a lot easier, I find, than doing a direct sac puncture, but I think it's a subset of patients that are suitable for this type of technique. Type 3 endoleaks, there are the type 3A and type 3B endoleaks. The A are limb disconnects, which fortunately are infrequent, and the type 3B endoleaks are the fabric tears, which occasionally occur. This is one such case of a limb disconnect, easily treated with an extension between the two devices. Here's one of the old AnCure devices that again, exemplifies going outside the instructions for use. If any of you in the audience have ever used the AnCure was supported at the top at the bottom and unsupported in its limbs. And so as a way to treat kinking of the iliac limbs, we used to put bare metal stents inside of those. Well, long term, the problems are that those bare metal stents can erode through the fabric and you end up with a type 3B endoleak. This is one such case. This was corrected with an AUI device and a FemFem bypass. Occasionally, you'll see late complications for fabric erosion with other devices. This is one such case. You can see a CT scan here with contrast emanating from the main body of the graft. On the angiogram, you can see some irregularity, the left iliac limb, and also the main body of the graft. There appears to be a little blush there. We easily were able to pass a wire right through that area, demonstrating where the endoleak was. Good news is you could just treat this with relining of the device, which is what we did. And then type 4 endoleaks. These also are infrequent. They're primarily suture hole bleedings from the devices themselves. Then you have the seromas or hydromas that occasionally occur with the PTFE grafts. Most of these do not require any treatment. So occasionally you'll reline the grafts. If you were to open it up, this is what you see. You see a lot of this fibrinous material inside there. And occasionally these patients will have rupture of the graft with pain associated with no hemodynamic compromise because there's no blood in the aneurysm sac itself. Migration, this is the Mickey Mouse sign. This is when the main graft has come down, migrated, and folded over on itself. These patients can present with an acute aortic occlusion. And then this one, I think, very nicely illustrates some of the problems with going outside the IFU. Again, this is a patient that Dr. Rodriguez had taken care of. It was transferred from an outside institution. You can see that there's virtually no neck there. And the only way to treat this was to take the thing out. What I find worrisome is when I look at this, and I think all of you can easily see that there are multiple devices. There are multiple different devices. And so what that tells me is that whoever put this device in doesn't have a clear understanding of case planning and the appropriate devices, because many of these cases should be done with just a few pieces, and it certainly shouldn't require multiple different manufacturers. So in summary, I think we're going to see some increasing failures of EVAR, particularly if you continue to surveil those patients. The patients will sometimes can present asymptomatic or limb ischemia, and occasionally with rupture. But the key thing is that if you go outside the IFU, this is where you're going to predict the problems. And I'll stop there.
Thank you, Mark. That was excellent. And again, as a cardiologist, interventional cardiologist, I just want to underscore your comments. Really, the pre-procedural planning, I think, and really understanding these devices is so vitally important. And I, too, see sometimes some of the things that you just referenced to, and it's all a function of poor pre-procedural planning. Ted, do you want to make any final comments before we break for lunch, or Zvonko?
No, I just think this is a very, very informative session. I congratulate you on your excellent case, and I think the speakers brought out the salient points we need to be thinking about.
Fantastic. Zvonko? So let's break for lunch, and we will reconvene here within an hour, and we're going to pick back up with another very interesting debate about off-label use or utilizing the devices outside of the IFU and whether or not we're doing our patients any good. Thank you.
Friday night, I'm going nowhere. All the lights are changing, green to red. Turning over TV stations, situations running through my head. Looking back through time, you know it's clear that I've been blind, I've been a fool. To open up my heart to all that jealousy, that bitterness, that ridicule. Saturday, I'm running wild, and all the lights are changing red to green. Moving through the crowds, I'm pushing, chemicals are rushing in my bloodstream. Only wish that you were here, you know I'm seeing it so clear. I've been afraid to show you how I really feel, admit to some of those bad mistakes I've made. And if you want it, come and get it, crying out loud. The love that I was giving you was never in doubt. Let go your heart, let go your head, and feel it now. Let go your heart, let go your head, and feel it now. Babylon, Babylon, What on earth is going on in my heart as it turns as cold as stone? Seems these days I don't feel anything unless it cuts me right down to the bone. What on earth is going on in my heart? Cause my oh my, you know, it just don't stop. It's in my mind, I wanna tear it up and trying to fight it, trying to turn it off, but it's not enough. It takes a lot of love. It takes a lot of love, my friend, to keep your heart from freezing, to push on till the end. My oh my. What on earth is going on in my head? You know I used to be so sharp. You know I used to be so definite. Thought I knew what love was for. I look around these days, I'm not so sure. No, nah, nah. My oh my, you know it just don't stop. It's in my mind, I wanna tear it up and trying to fight it, trying to turn it off, but it's not enough. It takes a lot of love. It takes a lot of love, my friend, to keep your heart from freezing, to push on till the end. My oh my, you know I just can't win. I burn it down and come right back again. What kind of world is this we're living in, where you never win? It takes a lot of love. It takes a lot of love these days to keep your heart from freezing, to keep your spirit free. Ah, my oh my. My oh my, you know it just don't stop. It's in my mind, I wanna tear it up and trying to fight it, trying to turn it off, but it's not enough. It takes a lot of love. It takes a lot of love, my friend, to keep your heart from freezing, to push on till the end. My oh my, you know it just don't stop. My oh my, you know it just don't stop. Just don't. My oh my, you know it just don't stop. My oh my, you know it just don't stop. My oh my, you know it just don't stop. Well, my oh my, you know it just don't stop. My oh my, you know it just don't stop. My oh my, you know it just don't stop. Feel the weight of the passing time of these crazy faces run through my mind, and this song is but a teardrop to my eye. We can't tell the bottle from the mountain top. No, we're not right. I see this world knees are shaking, but I just can't stop. You can't tell the bottle